and then we hand over the proceedings.
Right.
Right.
Meeting is live now. So a
We
very
are
good
live, sir.
a very good morning to all the viewers of Momentum. This year has been remembered probably for all the wrong reasons. But luckily for us, this year is ending and this is going to be the last Momentum webinar for this calendar year, 2020. And it's on a very interesting topic from a society which is now coming into recognition, but has existed since a very long time. If we see our Hindu mythology, our Hindu literature, ancient literature, the feet have a very, very important role. And keeping this in mind, a very dynamic Professor Pandey in the year 1979 conceptualized the formation of a subspecialty society, that is the Foot and Ankle Society of India. But however, till 1987, this dream couldn't be turned into a reality. In the Indian Orthopedic Association annual conference in 1987, in the presence of the late Mother Teresa, the Indian Foot and Ankle Society was formed. At that time, it was just the Foot Society, but over a period of time, this has become the Indian Foot and Ankle Society, and today it has probably more than 1,500 members as a part of it. It is our privilege to invite the Indian Foot and Ankle Society as our guest society for today, and the topic, which is diabetic foot, is also probably a topic which is very, very important, because once upon a time we thought that this is basically the milieu of general surgeons. But as of today, orthopedic surgeons are actively involved in participation and treatment of diabetic foot. Before we go on, as a tradition, we would have all the office bearers of the Indian Orthopedic Society annual conference, which is to be held next year in Mumbai, that is IOCON 2021, to give their opening remarks. So I would request Dr. Ajit Shinde, the president of MOA and organizing chair of IOCON 2021, to give his opening remarks. This would be followed by Dr. S.S. Mohanty, who is the president of BOS and co-chair of IOCON 2021.
Can you hear me?
Dr. Ram Chadda. May I now hand over the proceedings to Dr. Ajit Shinde. Sir, we can hear you, Dr. Shinde.
I think is internet some problem.
Yeah, so why don't we have Dr. Mohanty address us, and then we can go to Dr. Shinde once he joins. Mohanty, sir.
Okay. Good morning, dear friends. Greetings from Bombay Orthopedic Society and greetings from the organizing committee of IOCON 2021 to be held in Mumbai. Now, today is an important day for us because Indian Foot and Ankle Society is going to take over the academics today from the IOCON 2021, and the momentum is still on. Now, dear friends, as 2021 is coming to an end, as Dr. Swapnil told that there is a lot of hassles in this year, but we take all these hassles to our advantage. So we adjust all these adversities to our advantage. So we had a lot of teaching work and a lot of webinars where we disseminated a lot of knowledge about what we were not doing probably in the yesteryears years. So today the most important topic is the diabetic foot, and at least all of us tell that foot is not stinking. And this is mostly neglected by orthopedic surgeons. In my institute itself also, the diabetic foot is always referred to a general surgeon, but we have a tremendous role to play as an orthopedic surgeon for the management of diabetic foot. And my very good friend, I welcome Dr. Mahendra Kurjakar, who is the president of Indian Foot and Ankle Society, and other friends in the society, as well as Alok Jain is there, very old friend. Alok, hi. And hope we will disseminate the knowledge of caring for the diabetic foot henceforth. Thank you very much. Now I hand over to Dr. Ajit Shinde our organizing chairman of IOCON 2020. Probably he is the, he's live now. Dr. Shinde sir, please. Yeah, Shinde sir, you're okay?
Can you hear me?
Yes, sir.
Yeah. Can you hear me?
Yes, sir.
Yeah.
Good morning, dear friends. I am Dr. Ajit Shinde, MOA President and Organizing Chairman of IOA Mumbai. Welcome you all for second inning of Momentum. As there was gap of 1 month, we have interval month of 1 month. As mentioned, Momentum joint venture of MOA, BOS, IOA Organizing Committee. It is nothing but a showcase trailer of IOA Mumbai. For every episode, we are involving different chapter or society of IOA for better communication and awareness of IOA Mumbai. Today, as mentioned in flyer, guest society is foot and ankle. I like to thank President Kutsekar and Secretary K.S. Anand for their participation and selecting common challenging topic of all peripheral orthopedic surgeon diabetic foot, where there is a dilemma regarding investigations, management options, medical
I think there is some disturbance.
Dr. Swapnil?
Yeah.
I think Dr. Ram can speak and then we can start.
No, sir is back. Dr. Shinde is back.
You have to unmute yourselves.
Sir, please
Shinde sir.
unmute.
Swapnil, we can
Yeah.
go ahead with
Ram,
Dr. Ram
yeah.
does. Yeah.
Good morning, friends. I think Dr. Ajit Shinde has some connection issues, but let us put the best foot forward. I welcome all my colleagues who are probably dealing with the most important part of the human skeleton, not just physically, but as a structure and a support to enhance our productivity. I look forward to spending the next 1 year taking the right feet with us in our journey as we move towards IOCON Mumbai. 20th of December today, around this time, would probably have been the valedictory function of IOCON 2020 Mumbai. But I'm sure the next year will be different. Dates do not decide the future. 19th of December, 5 years back, India scored 700 and X number of runs for 7 wickets, the highest ever score. And yesterday, we crumbled to 36. Where you have a will, there is a way. So let us all put our best foot forward, find the way, rather than look for excuses of not doing things. I'm extremely happy and privileged to have Dr. Kutsarkar, Dr. Anand, and the entire IFAS, Pradeep Munut, my good friend from Mumbai, and my very, very dear friend from all over the country, to help us enhance knowledge, percolate it into wisdom, and treat the sweetest part, which is diabetic feet, that we address day to day. Thank you very much for being here. I would want Dr. Shinde to complete his presentation for the welcome address, and then move forwards. Dr. Shinde, please take over, sir.
I think there is a connectivity problem. Repeatedly, there is interruption.
No problem, sir. You carry on now.
So please complete your address, and then they can begin the proceedings.
1 minute.
Yes.
Good morning, dear friends. I am Dr. Ajit Shinde, MOA President and Organizing Chairman of IOA Mumbai. Welcome you all for second inning of Momentum, as there was interval of 1 month. Momentum is a joint venture of MOA, BOS and IOA Organizing Committee. It is It is nothing but showcase trailer of IOA Mumbai. For every episode, we are involving different chapter or society of IOA for better communication and awareness of IOA Mumbai. Today, as mentioned in flyer, guest societies Foot and Ankle. I like to thank President and Secretary for their participation and selecting common challenging topic of all peripheral orthopedic surgeon, a diabetic foot, where there is a dilemma regarding investigations, management options, both medical as well as surgical, uncertainty of the prognosis, and socio-economical problems of the patients. One must know the preventive measures not to develop wound to foot. At the ultimate goal of treatment is to achieve functional foot with which patient can maintain his walking exercises which help him to control the sugar. Today, we are having the masters in this field who will share their knowledge, wisdom, experience to us.
Sir, with your permission, can we proceed with the meeting?
Yes.
Yes.
Please proceed.
Thank you very much, President Sir, Dr. Mohanty, Dr. Ram Chadda. We have a very interesting and vibrant program planned by Dr. Kumar Shantanu and Dr. Mahendra Kutchatkar. So may I now welcome both of them and pass on the proceedings to the Indian Foot and Ankle Society. Welcome, sirs.
Hi. Hello.
Yes, thank you so much, Dr. Swapnil. I, Dr. Kumar Shantanu Anand, the Secretary of Indian Foot and Ankle Society, express our heartfelt thanks to the BOS and MOA, Dr. Swapnil Kenny, Dr. Ram Chadda sir, and Dr. Ajit Shinde in particular. We will go forward. We have a galaxy of stars, not only from Indian Foot and Ankle Society, but also we have a very senior diabetologist and a very senior vascular surgeon. So it's going to be a very comprehensive webinar on diabetic foot. May I now take the opportunity to welcome our current president, Dr. Mahendra Kutchatkar, to start his talk. Dr. Mahendra Kutchatkar, sir.
Surendra.
Thank you. Can I start?
Yes, please.
Yeah, okay. Good morning, everybody. Thank you very much to BOS for allowing us to share something on diabetic foot. I think that's the topic that has always been neglected and put under the carpet. It all started by the fact that my mother is a diabetic patient and she developed a small ulcer on her foot. This was a few days before I got inducted as the president of the Indian Foot and Ankle Society, and I was wondering what should my theme be. And I don't know, it was like a bolt from the blue. I thought, why not use this opportunity to explore? And the ulcer on my mother's foot healed by just offloading by a simple orthotic. And I said, this is the opportunity for us to save the, start a topic and start a campaign on how to save the diabetic foot. So that was this is the president's theme this year for the Indian Foot and Ankle Society. And along with Shantanu, I said, we must start this with this topic which is so close to my heart. I think diabetic foot has always been something that has been not being treated adequately simply because it has been taken away by our own branch. As an orthopedic surgeon, we neglected it. We just sort of stayed away from it, thinking that we have no role to play, when actually the pivotal role belongs to the orthopedic surgeon besides the other fields. So let me just start my presentation. Can you see it?
Yes, please go ahead.
Okay. Right. So how do I enlarge this? Okay.
Slideshow.
Oh,
Slideshow.
yeah. Slideshow. I'm just looking at where that is. Okay, right. I got it. Okay. So I think the first thing is that we shouldn't be treating diabetic foot alone. And this is the basis. I mean, this is where it should start from. It has to be a teamwork. We have, the entire range of professionals that are required to treat the diabetic foot, starting from the general surgeon who is right now treating it all by himself with a little bit of help from the diabetologist. But I think the role of the orthopedic surgeon has to increase in order to make a real impact on the final outcome of this diabetic foot. We need a microbiologist to treat the infection. We need the vascular surgeon to salvage the foot. We need the plastic surgeon to achieve a soft tissue cover. And the orthotist, the wound care nurse, and the counselor. I think these people are so vital to the team. How do I change this slide? It's not moving.
Down arrow, you can keep going. Down arrow.
Click on the
your
screen.
laptop. Click on the screen and down arrow.
Okay, right. So the ingredients of a diabetic foot ulcer are four. First is the neuropathy that you definitely, have to understand the neuropathy because that's where it all starts from. You have to look at the vascular problem that occurs in diabetes, the immunological problems. There is a defective immune system, and finally, I've added the term ignoropathy. It's because the ignorance of the patient as well as the entire, treating members that this needs to be treated as a team member. One cannot treat it alone. Now, this slide really shows you how the mechanism of action of how the diabetic foot ulcer starts. It starts with certain predisposing factors, starts with the angiopathy problem, with the neuropathy. Now, you could have one of these or all of these together, but usually it starts with the neuropathy first, and gradually the vascular issue makes it more and more complex. But the underlying abnormal immune response and then the other factors like infection just makes this matters worse, and finally the patient lands up with a gangrene. At-risk stratification is extremely important. When a patient comes to you, you have to be able to look at these points. You have to see if there is a loss of sensation, which we can estimate by examination. If the patient has a loss of sensation or a mild degree of diabetic neuropathy, we have to be very, very careful. If the patient has pre-existing deformities, which can result as a result of Charcot's or a motor neuropathy, peripheral arterial disease, a poor glycemic control, If you also have certain pre-ulcer lesions like corns, callosities, or infected nail beds, previous history of ulcers, long-standing diabetes, ill-fitting shoes. I think ill-fitting shoes is one of those things which is always, not even looked at. Nobody even watches what type of footwear a diabetic patient wears, and half of the problems lies in these ill-fitting shoes. And of course, associated comorbidities like chronic renal insufficiency. You need to look at these areas of the foot. This is where the problem would start. So these are the pressure points. And once the deformities occurs, these pressure points are going to increase, and the chances of getting an ulcer on these areas are very, very high. These are some of the lesions that you could see: a dry nail, some of the nails which are overgrown, some corns under the toes, between the interdigital spaces. Even a small tiny speck on the pulp of the toe cannot be neglected, because this can eventually lead to a full-blown ulcer. It starts with a hot spot, which we have to be very, very careful. And all this is required. And we can pick up these things by educating the patient, because you can't be with the patient all the time. So patient should be watching his fit every day, morning and night, and look for these early danger lesions. In the clinical evaluation, you have to look at the visual. Visually, you have to look at the ulcer. What is the size? Then very important to assess the depth, because the depth of the ulcer will decide how complex this ulcer is. You also have to put a finger on your pulse, look at the vascularity, look at the other changes of chronic vascular insufficiencies, the skin temperature, the gait of the patient, shoes, deformities like hammer toes, claw toes, Taber's feet. All these things have to be assessed, and finally a detailed neurological examination to understand the degree of neuropathy. Now, when you look at the ulcer, it has got three components: basically the wound itself, the blood flow, that is the ischemia, and the infections. So if you have a non-infected wound, things are easier. If you have a ischemic ulcer and a diabetes, it still makes it more complex. So all these three things have to be handled together in order to achieve the best outcome. The principles of management, basically we have to first do things. The first is you have to offload the ulcer. If you do not offload the ulcer, no matter what you do to the ulcer, it's not going to heal. So as an orthopedic surgeon, or as any doctor who is going to treat a diabetic ulcer, it is extremely important that the primary thing to be done is offloading of the ulcer. Second, you manage the ulcer itself. If the ulcer is infected, achieve a good control of infection. If you find that there is poor blood flow, you have to improve the blood flow for a good healing. Correction of those deformities are extremely important, so that the deformity does not recur and the ulcer does not come back. Optimizing the glucose levels, the lipid levels, and the blood pressure are extremely crucial for a good outcome. Controlling the comorbidities, and of course, the patient has to be asked to quit smoking if he is a smoker. So when we say offloading, is basically there are many ways of offloading. But if the ulcer is non-infective, is non-ischemic, the patient can go into a total contact cast, which is a non-removable type of a offloading brace, or you can put the patient in a non-removable type of a splint, like a cam walker or a crow splint, if you are worried about infection or ischemia. But a total contact cast is one of the best modalities, which really gives you the best outcomes. But the patient has to be washed properly, and putting the total contact cast is an art itself. So it has to be done properly to get the best results. So you can also offload it by just telling the patient not to wet bear, or give him a walker or a crutch. That is another way of doing it. But generally, if you want the patient to be functional, it's nice to give them a total contact cast or a cam walker with a proper cutout in that area. So once you have offloaded the ulcer is on its way to heal. Now, as far as ulcer management is concerned, superficial ulcers, you just need to debride to bleeding margins. Provide a moist dressing. A simple saline dressing is all that is required. If you are suspecting any amount of infection, you can start on an oral broad-spectrum antibiotic. If the ulcer is deep, which you can do by probing the ulcer, if it is deep to the tendon and the bone, and if there is a deep abscess, you have to drain it. Now, these ulcers which are deeper, they might require specialized dressings like hydrocolloid or alginate dressings. Parenteral antibiotics are absolutely important, because if the ulcer is bone deep, you have to suspect osteomyelitis, even if it doesn't show on the X-ray. Ulcer which is bone deep has to be established infection, and osteomyelitis, and has to be treated like a osteomyelitis ulcer. And you have to plan for a revascularization. Frequency of ulcer evaluation is basically every week. It can be done by the doctor or the wound nurse. The depth of the wound here is very important. There's an 85% of chance of osteomyelitis if you see bone through the ulcer, or you can palpate it. Now you have to watch for the degree of exudation, the degree of infection, and degree of ischemia. This will decide how aggressively you are going to treat the ulcer. Now, if you suspect osteomyelitis, then of course, these are the parameters that you look at. If the ulcer is greater than 2 centimeters square, or a deeper ulcer, which is more than 3 mm deep, or an ESR, which is about 70, the chances of having osteomyelitis are much higher. For some reason, the slides are not moving. The type of ulcer dressing is, there's a huge range, but any ulcer, provided you keep it moist, a simple moist dressing will help in autolysis and exudate absorption. A simple saline dressing is good enough, but sometimes if you want for convenience, you could use a tegaderm. If there is a less exudative wound, you could use sucrose, actosulfate impregnated dressings or hydrocolloid dressings. Sometimes for a big cavitatory wound and very exudative wounds, you could use calcium alginate or a foam dressings. These are all ready-made dressings which are available. They are expensive, but they may be needed only in certain rare cases. In terms of antibiotics, you could use sulfur sulfadiazine, vaxithracin, neosporin, or carexomar iodine for infected wounds. One thing that you need to avoid is avoid hydrogen peroxide, avoid iodine, sodium hypochlorite solutions, which are traditionally been used because they cause a lot of damage to the wound. Sorry about this because I don't know why it's not changing. So last few slides. Now the special agents that are used in delayed ulcer healing, you can use a platelet-derived growth factor, collagenase enzymes to allow healing of the necrotic ulcers. Back dressings can be used in a large wound, which will help to shrink the wound. Pulse lavage, ESWT, and HBO therapy, though they are not recommended as a standard treatment, they could be used in the rare cases. Control of infection. Now, all superficial infections need to be treated with oral antibiotics, depending on the culture. We need to drain the abscesses and the deeps, open out all the dead spaces, because if you do not allow these dead spaces to drain out through the ulcer, they are going to progress along the tissue planes and cause more infections. Trim the ulcer margins, don't allow them to remain proud. Decompress all the compartments, and parenteral antibiotics for deep ulcers. And generally, a diabetic ulcer has a mixed infections, a gram-positive and negative, along with obligate anaerobes. And we need to treat them not empirically, but by using a proper culture sensitivity report. Finally, tissue perfusion has to improve. So if the ankle pressure is less than 50 millimeters, or an ABI of less than 0.5, toe pressure less than 30 mm, transcutaneous pressure less than 25, or there is no response to healing at 6 weeks, then definitely we have to get the vascular surgeon into picture. And my last slide, these special procedures that we can, as orthopedic surgeons, do lots of the corrective osteotomy so that we can remove the pressure points, especially in a thing like a Charcot's foot. The Charcot's foot, you need to correct the deformities before the ulcer to heal. You need to do the exhaustectomies wherever there is a prominent bone, dissecting the metatarsal heads, and all these things will help to prevent the ulcers from recurring. Of course, revascularization is extremely important, not only to treat the intractable ulcers, but to cure the rest pain and the impending gangrene. And lastly, the skin grafts, the collagen matrix xenografts, skin substitutes do have a role to play in other special conditions. And with this, I hand over the presentation to the next speaker. Thank you very much.
Yeah, thank you, President Sir. That was really a comprehensive and a nice presentation on the overall picture of diabetic foot. Next, the speaker happens to be a very renowned physician, somebody who has been at the forefront of fight against diabetes. None other than my elder brother, Dr. R.K. Modi sir, who has been the Secretary of Clinical Cardio-Diabetic Society of India, Bihar chapter, who has been the Vice President of Clinical Cardio-Diabetic Society of India, who has been waged a lot of battle against diabetes and diabetic foot. So it's my proud privilege to welcome Dr. Modi, sir.
Thank you, Dr. Santanu. I'm not able to share my slides because other participants are sharing it.
Yeah, Mahendra sir, could you please stop sharing?
Yeah.
Right, you can do it now.
Yeah. I can do it.
Yeah, I did it.
My slides are visible now?
Yes.
I am audible also?
Yes, very much, sir. Loud and clear.
So, welcome. I must thank to the organizer who has given me this great opportunity to sit among renowned foot surgeons, orthopedic surgeons, and great learned person, and with great audience. Thank you, sir. So I am sharing my presentation. The topic is management of diabetic foot in physician's office. Diabetes is a chronic metabolic disorder affecting nerves, eyes, kidney, blood vessel, and heart.
So make it full screen. Sorry to interrupt, but make it full screen. Yes.
Yeah. Diabetic is a chronic metabolic disorder, and that will cause neuropathy as well as vasculopathy. And diabetic foot disease is a result of either of neuropathy or vasculopathy, and sometimes it is a result of its combination. In India, 75 to 90% of major foot problem is due to neuropathy. So neuropathy is more common in India. Diabetic foot has become a matter of concern because it's a major cause of morbidity, mortality with great economic burden. Now, coming to the magnitude of the problem, inadequate management of diabetic foot disease can end in amputation of a limb. And it is the commonest cause of non-traumatic amputation of limb, and about 70% cases, the cause is diabetes. And in every 30 seconds, one limb is amputated somewhere in the world. ADA has estimated that 50% of limb with foot ulcer can be saved if both healthcare provider and patient fulfill their respective responsibilities. And we are sure that we physicians and we surgeons, we will definitely fulfill our responsibility, and we will make true the dream that we have to salvage a diabetic foot. Coming to the prevalence, the global prevalence is about 1.5 to 16.6%, and in India, the prevalence is 11.6%. Risk factor, Dr. Mahendra has nicely described. I'm just revising it: smoking, diabetic peripheral neuropathy with loss of protective sensation, peripheral artery disease, a foot deformity, chronic kidney disease, callus or corn, because these are pre-ulcerative lesions, history of diabetic foot ulcer or amputation, and of course, visual impairment and poor glycemic control is supposed to be one of the most important factors for the increased risk for a diabetic foot. Human foot is a great mechanical marvel. It has got 26 bones, 29 joints, and 42 ligaments. It has a very sensitive and protective skin blanket, rich nerve supply, and has great vascularity. Why we have diabetic foot disease and why not diabetic hand disease? Now, if we see the slide, this is showing the evolution of a man, which was a tetrapod in beginning, and then gradually he took the erect posture and became bipedal. So the erect posture causing the weight bearing only on the 2 feet. Before it was on the 4 limbs. That is the one most important reason. The other reason is the distance from the eyes. It has been increased. So, as Dr. Mahendra told, it is probably the most neglected part for individuals and of course for the physicians and surgeons, but we should give proper attention to the foot. So this distance again is a risk factor for getting a diabetic foot disease. And thirdly and fourthly are the pathological reasons. The nerves are long and slender in the extremities, so it will be affected in the neuropathy. Blood vessels will be affected by ischemic changes, and there will be vasculopathy and poor blood supply, giving rise to a diabetic foot disease. Coming to the spectrum, there may be subjective complaints and objective signs. Subjective complaints like dysphagia, which is probably the earliest sign, and this is due to the involvement of small fiber neuropathy, that is unpleasant sensation of burning, pain and tingling. We may get dry skin, numbness and loss of peripheral protective sensation, and reduced vibration sensation. These two important factors, in fact, there are a risk for development of a diabetic foot ulcer. And these are the features of large fiber neuropathy, and these can be easily diagnosed in our OPD. Then dermatophytosis over space, blister and bullae, callosity and corn, foot deformities like hamartose, hallux vulgus, diabetic foot ulcer, gangrene, and of course, Charcot feet or osteoarthropathy. So diabetic neuropathy affects foot by sensory, motor, and autonomic dysfunction. Dry foot, reduced blood flow are the features of autonomic neuropathy. And in motor neuropathy, we may have weakness and wasting of muscle crowding toes, cock-up toes, hallux vulgus, clouding of those structural changes we get. Vasculopathy causes reduced blood supply over the foot, and that is the important factor for diabetic foot. So diabetic foot, as this slide was shown earlier also, is the complex interaction between neuropathy, vasculopathy, foot deformity, and infection. Why diabetic foot needs special attention? Yes, it is because of poor wound healing. And why this is poor wound healing? Because of abnormal cellular or inflammatory pathway, fibroblast, neutrophil, advanced glycosylations in products, associated loss of protective sensation, associated neuroinflammatory response due to autonomic dysfunction, and wound hypoxia due to microvascular and macrovascular disease. So here we can compare a normal foot with a diabetic foot. In a normal individual, repetitive stress or trauma will produce inflammation and pain. And this pain and inflammation will go to the brain center, where we modify the gait. And this gait modification, appropriate gait changes, will heal the process. There will be tissue repair and there will be healing. But what happens in a diabetic subject? Even repetitive stress and repetitive trauma will produce inflammation, but no pain. So no signal to brain, and there will be continuous use of the affected limb, and it will result non-healing and later a foot ulcer. Paul Brand was a famous great surgeon with leprosy, and he worked in South India in mid-20th century. He was working, in fact, on the insensible foot ulcer of leprosy. And he described correct thing about the diabetic foot. The whole problem of neuropathic foot is really one of the mechanics, not of medicine. So the main pathophysiology is altered biomechanics that is in a diabetic foot. So this will give you the importance of offloading that Dr. Mahendra has already told. So there is 25% risk of developing an ulcer in a lifetime, and it results from mechanical trauma, and it is unnoticed due to loss of protective sensation. Commonest site is forefoot. Ulcer develops at site of high pressure zone, either side plantar or dorsal surface, caused by bony prominence, ill-fitting footwear, and toe deformity. And continuous abnormal pressure causes further tissue ischemia. Limited joint mobility is another contributing factor, and bony deformity and callus we should remember, because these are the marker of elevated plantar pressure, and that is a hot spot, in fact, described by Dr. Mahendra. So we have a rule of 50, that 50% of amputation, whether transfemoral or transpatebral level, 50% of the patient will have second amputation in less than 5 years of age. 50% of the patient will die in 5 years. That is very sad. We have another rule of 15, that 15% of diabetic patient will have a foot ulcer in their lifetime. 15% of foot ulcer will turn into osteomyelitis, and 15% of foot ulcer will end in sad amputation. we have to save and salvage the food. So these are the few foot ulcer slide. Coming to the examination part, inspection, palpation, one of the most important part is examination of footwear. And we can detect neuropathy by a simple 10-gram nylon monofilament and 256 Hz tuning fork. And biochistometry is other important tool for investigation of diabetic neuropathy. Vasculopathy can be detected by simple palpation of peripheral pulses, dorsalis pedis artery or posterior femoral artery. And so we have hand Doppler or vascular Doppler for measurement of ankle brachial index that will help to establish the diagnosis of vasculopathy. So examination of footwear is very important. We should discourage Hawaii chappal and ill-fitting shoes. And sometimes impression on this insole and outsole and wearing out of the outsole. Just look here. They point towards the high pressure area. So we must examine the footwear, and that is one of the important part in the management of diabetic foot. And how should be a good diabetic footwear? It should have a rigid outsole, like this, rigid outsole. It should have soft insole, made up of microcellular rubber. It should have a roomy toe box, wide mouth, extra depth of shoes with a counter. And these are the features of good diabetic footwear, and we should advise our patient to have a prophylactic diabetic footwear. Coming to the management part, it is a teamwork, as described by Dr. Mahendra. Multidisciplinary approach is required. Physician, surgeon, nutritionist, diabetic nurse, food care worker, diabetic educator, and of course, diabetic cobbler. All are important for salvaging of a diabetic foot. Proper work of diabetic foot is essential to establish neuropathy or vasculopathy or both. Tight metabolic control is essential and is a key factor. So we know in diabetes there is insulinopenia, and this insulinopenia is either due to the absolute deficiency or relative deficiency of insulin or insulin resistance. And it affects carbohydrate, lipid, and protein metabolism, and all will give rise to hyperglycemia, ketoacidosis, proteolysis, and protein degradation. So our purpose of metabolic control, prevention of hyperglycemia, prevention of ketoacidosis, prevention of hyperosmolar coma, prevention of dehydration, prevention of sepsis, and at the same time, promotion of normoglycemia, control of infection, and fast healing and attainment of a normal productive life. And this we can achieve by prompt diagnosis, timely treatment, timely intensification of diabetes control by insulin, especially short-acting, with frequent monitoring. We should remember our target blood sugar level. Fasting should be less than 110, postprandial should be less than 140, and random blood sugar anytime should be less than 180 milligram. And mode of administration of insulin can be subcutaneous or insulin infusion by insulin pump as per need. OAD are not preferable in period of stress. In case of emergency, our goal of management is fluid resuscitation, reversal of acidosis and ketosis, reduction in the plasma glucose concentration, replacement of the electrolyte and volume loss, identification of the underlying cause. And this we can achieve by providing short-acting insulin, intravenous fluid administration, electrolyte supplementation, use of alkalizing agent like sodium bicarbonate, and use of appropriate antibiotic, which should be empirical in beginning. Later, definitive antibiotic treatment can be given after the culture report. So imaging technique have a definite role. Their definite role. The first step is to classify diabetic foot disease. This slide is also shown by Dr. Mahendra. We have to classify whether the condition is non-limb threatening, limb threatening, or life threatening. Life threatening diabetic foot disease is characterized by presence of infection, metabolic instability, and there will be feature of systemic toxicity like fever, chills, tachycardia, hypotension, hyperglycemia, confusion, acidosis, azotemia. So these are the warning signs, and we must take care. We know minor problem becomes major and life-threatening in diabetes if not treated early. So a non-limb threatening condition may become limb-threatening, and if not cared early, or if not taken proper care, it will turn into the life-threatening condition. Non-limb-threatening conditions like callosity corn, dermatophytosis of the space, deformities like hallux valgus, hamartos, fissures and cracks, hypertrophic bursitis can be managed in outpatient basis by giving proper advice regarding foot care and footwear. Minor OPD procedures for callus and corn removal can be done. Appropriate use of antifungal is important. Moisturizing lotion is very important for cracks and fissures, and we can advise customized preventive footwear for foot with structural deformity and foot at risk, that is foot with loss of protective sensation. We can use empirical antibiotics for a short period in OPD. Limb-threatening and life-threatening diabetic foot conditions needs indoor admission and help of a surgeon, foot surgeon, ankle surgeon, general surgeon, orthopedic surgeon for proper management. So identification of such condition is very vital, very important for early referral. But before sending to a surgeon, a physician must talk to the surgeon and discuss the modality of management regarding correction of dehydration by appropriate intravenous fluid, insulin infusion for correction of hyperglycemia, selection of empirical antibiotics in consideration for renal status, because most of the time there may be some renal impairment before the culture results comes. In limb-threatening condition, we can use these antibiotic combination as an empirical treatment. For life-threatening condition, a combination of piperacillin tazobactam with amikacin is suitable. If a physician must tell that the surgeon that the best dressing material for diabetic foot, although we have newer diabetic dressing material, but one of the best material for dressing is normal saline, and use of Savlon, betadine, hydroxyl peroxide, eosol is not suitable for diabetic wound because they have direct cytotoxic effect to fibroblast and keratinocyte. Use of topical antibiotic is good for keeping the wound moist. It is also being told by Dr. Mahendra. Always remember, the final choice of antibiotic depends on the results of culture sensitivity. Clindamycin, azithromycin, and moxifloxacin can be used safely in patients.
Yeah, Dr. Modi, sir, we cannot hear you. I guess some problem with the connection.
Shantanu, can you call him up?
Yeah, I'm trying to, but कोई problem. Okay. Sir, unmute yourself. Modi sir, unmute yourself. Yes.
Yeah, my slides are not coming now.
No, no, not at the moment. Please.
Yeah, just a minute. Just a minute. I will finish in a couple of minutes.
Yeah, share your screen. Share your screen.
Yeah.
Go full screen. Yes.
So, clindamycin, azithromycin, and moxifloxacin can be safely used in patients with impaired renal function, but the risk mentioned antibiotic dose adjustment is very necessary. Now, final principle of management of diabetic foot from surgeon's view, from physician's view, it's good metabolic and glycemic control, appropriate use of antibiotic, extensive debridement by surgeon, and of course, offloading. So to conclude, prevention is the first and the last weapon for the management of diabetic foot. A new diabetic patient with his first interaction with physician or a diabetologist, is being instructed about food care. So it is a preventive strategy. And even a serious complication occurs and ends in a sad amputation of a limb, he is again instructed to take care of the unaffected remaining limb and the care of the stump. So again, a preventive strategy. So the disease and the journey begins with prevention and ends in the prevention. So diabetic patient must love his feet, and we must respect their fate. So thank you very much for your patient listening, sir.
Thank
Thank
you.
you, Dr. Modi. It was a nice presentation. Thank you.
Thank you. Thank you, Modi sir.
Thank you.
Any question from our faculty to Dr. Modi sir? And any question from our participants, our audience, they can type the question and send it to us on YouTube channel of this live presentation. Next speaker is Dr. Kamerkar sir from Pune, who happens to be a very renowned vascular surgeon, and apt that he is still in his scrubs. So Kamerkar sir, it is our privilege to have you here. You have a 35 years of rich experience. I look forward to listening to you, sir. Dr. Kamerkar sir, thank you.
Thank you, Dr. Kumar, and thank you, Dr. Mahendra, for giving me an opportunity to share my experience in preventing amputations in diabetic foot. It's a very common problem, and everybody. Let me share my.
So while you are sharing your screen, I have a question to Dr. R.K. Modi, sir.
Yes, Shantanu, I'm ready.
Yeah. You said there are certain anti...
Are my slides seen now?
No, not at the moment.
Okay.
So if there is a serious infection, would that time, would you, for the purpose of dressing, use betadine or things like that? Or because sometimes it is good to have a good granulation tissue first. So until the time granulation, I can understand that when there is a granulation tissue is there, then the use of hydrogen peroxide, betadine and catoxamer is not advised. But when it is a fulminant infected wound, would you use betadine and hydrogen peroxide at that time?
Ideally, these chemicals are more cytotoxic, and probably they will hamper the process of healing. But we can have a good another dressing material for proper healing, and that is platelet-derived growth factors, and they are being used nowadays.
I think Dr. Kamerkar is in this presentation.
Are my slides seen?
Yes.
Go to full screen. Yeah. Perfect. Thank you.
So I'm just going to kind of elaborate for next 10-15 minutes. What's our role in amputation prevention in diabetic foot? Essentially, it's a limb salvage through the revascularization. So how to prevent? I mean, there are a few points I thought I would like to cover. Presentations of vascular diabetic lesions. Then the revascularization certainly can improve the outcomes. There's what is the right time and favorable lesions for treatment. And in today's era, more and more endovascular procedures are being done over open surgeries, and how useful and better than they are for open surgeries, and when to refer to a vascular surgeon. We all know that too many diabetic patients suffer the same fate. And these are some of the common clinical issues what we see with gangrene, sometimes with the weight gangrene, sometimes you get these non-healing ulcers like atrophic ulcers. So it's a global management and it's a global approach, which is a multidisciplinary approach is a must. So this kind of scenarios we do get in a clinical practice with bad gangrene and necrotic foot. So when we look at diabetes and foot, about 50% have peripheral vascular disease. They also would have sometimes neuropathy and infections, as we heard earlier. Many of times, because of improper footwears, they form corns, callosities, shoe bites, ulcers, infections, and sometimes that can lead to weight gangrene. If you look at diabetics with peripheral vascular disease, they would present either with claudication, which generally is lesions at one level, or a critical limb ischemia, which is lesions at 2 or 3 levels. And tibial artery disease have to be addressed, as we all must understand and know that many times before I started mainly vascular practice and all my vascular colleagues across the country, many times the tibial disease was kind of left for nature to take care. But yes, in diabetic foot, especially tibial artery disease have to be addressed. So femoral, popliteal, and tibial are the most common segments involved in diabetics with peripheral arterial disease. It's generally widespread and rapidly progressive. There are increased calcifications in metatarsal and digital vessels as well. There is a basement membrane thickening, but it is non-occlusive, which is important to know. Many times they have autosympathectomy. They would have a higher ankle brachial indices because of calcified arteries, but the toe pressures would be more accurate to determine in these patients. And long-term patterns of grafts are as good as in non-diabetics. There are certain facts with peripheral artery disease in diabetes, because we all know ischemia may complicate up to 50% of diabetic ulcers. Up to 40% of diabetics with gangrene or severe limb-threatening infections have palpable popliteal pulse, and that's where the role of distal bypass or endovascular tibial interventions come into play. Relative sparing of pedal vessels, therefore aggressive vascular evaluation and treatment is essential for healing ischemic ulcers. Revascularization must be considered for chronic non-healing ulcers too. They are more susceptible for foot problems due to neuropathy, vascular insufficiency, and altered response to infection. They would have a somatic or autonomic neuropathy, which would cause ulcer development. The systemic signs and symptoms are late, so rely on uncontrolled and unexplained hyperglycemia as a reliable sign of serious infection. So end of the day, diabetes is a vascular disease. So revascularization of vascular beds is the key. And that's where the early referral to a vascular surgeon would help prevent many amputations. So why is it necessary to treat the peripheral arterial disease early, more so in diabetics? Because the symptoms would worsen in 25% of the patients. 5% would require amputation within 5 years. Around 5 to 10% have critical limb ischemia with the risk of limb loss, and increased risk of mortality primarily for cardiovascular causes. If you look at these causes of amputation over a period of years, soft tissue infection, non-healing ischemic ulcers, and osteomyelitis more in diabetics would lead to amputation as compared to non-diabetics. So this is how they basically present to us to begin with. And that's where we really need to take early and good care of these patients to prevent major amputations. And again, ischemia also is a main element for amputations in diabetics. So influence of arterial disease on healing, provided the extent of necrosis and infection allows a local procedure, the presence of peripheral arterial disease is the most important determinant of healing. So a success in diabetic foot management, a good diagnosis and correction of ischemia would lead into a well-perfused foot. What does it allow? It allows foot salvage procedures like minor amputations, debridements. It's possible to have minor amputations and better management of infections because of the reach of antibiotics. So the need for revascularization is a therapeutic goal with diabetic foot with critical limb ischemia to save life, to save the limb, to avoid major amputation, and to preserve plantar standing. And end of the day, combining these would also save the cost. So revascularization certainly would be cheaper than amputations in diabetic foot with peripheral arterial disease. It's a challenging problem because of the accelerated and aggressive atherosclerosis. Limb salvage is possible even in extensive tissue loss, provided the heel of the patient is intact. The results are comparable as in non-diabetics, and major amputations can be avoided in almost 80 to 85% of these patients. So the early involvement of vascular specialists is key to save legs and minimize complications, repeated procedures like debridement, etc., and most important, overall cost. I mean, this is very familiar. Patient present with this gangrene of single toe would need go for amputation. Wound doesn't heal because poor vascularity. Second toe gangrene, another amputation, non-healing, forefoot amputation, and land up with below knee amputation. So what are the limb salvage procedures? It's limiting the amputation to transmetatarsal level to have a functional foot. To heal the post-debridement ischemic wounds and amputation sites, dry gangrene of toes after amputations, non-healing ischemic chronic wounds. And generally we see that occlusion is 2 or more levels, but blood should be directly brought in foot for a quicker healing. It's a pulsatile blood which needs to be brought into the foot. And in order to plan a limb salvage procedure, we need a good angiography. And DSA is a must, whereby any vessels less than 5 millimeters, we need to have a proper DSA visualization of occlusive disease like this is popliteal and TP trunk. Now, this looks very ghastly picture with lower extremity revascularization. You can see thighs open here. There's a tunnel going through from the bypass from thigh to the below the knee. And these kind of bypasses, we're still doing it. But the incidence and occurrences of these distal bypasses have gone down considerably and tremendously because of newer and newer endovascular procedures. And imagine patient undergoing this for just a small gangrene of the toe, but it was required then to prevent amputation of the toe. These were the distal bypasses where the graft is anastomosed on the distal popliteal below knee or any of the tibial arteries or even up to dorsalis pedis arteries. But there are certain pitfalls of distal bypasses because arteries many times are heavily calcified, may make the anastomosis difficult. The distal anastomotic site may be close to the infected or debrided open foot wound. And of course, many of these would have a comorbid cardiac and renal conditions. This is just an example of a small, this was a calcified artery just above the ankle, and we had tried endovascular intervention here, but the wire wouldn't go through. It caused a dissection, and we replaced locally with a small vein graft here. And post-surgery, after the debridement, wound is granulating very nicely and contracting as well. So over a period of time, all the vascular colleagues and surgeons across the globe have moved on from open vascular surgeries to the endovascular surgery. Of course, I mean, in every patient, it may not be possible. Some patients, we still need to do open surgeries. So the tibial angioplasties, these are the limb salvage in chronic critical limb ischemia, beneficial in diabetics, good alternative to distal bypass. What's the new and encouraging? We're for limb salvage by tibial angioplasty. We have availability of special long balloons up to 220 centimeters. There are drug-coated balloons available and good new wires for navigation across the occluded segments. Unlike coronary, where your length of occlusions are very small, here we have complete tibial arteries across the leg also could be occluded. The main aim is to heal the wounds of septic foot or amputation of toes. Both endovascular and surgical revascular are complementary and sometimes may need both. Here's a typical example. I thought I'll share 2-3 examples of this. Diabetic 62-year-old male, long-standing ischemic ulcer with toe gangrene, severe ischemic leg pains at night, previous coronary bypass, LV is poor, 20%, mitral regurg grade 3, serum creat 1.6. These are the kind of typical patients we see. And he presented with this. We can see the multi-segment stenotic lesions in the tibial arteries on both anterior as well as peroneal. And this is a picture where you can see complete occlusion of the tibial arteries beyond middle third. And after dilatation, the entire arteries are opened completely and nicely. And that certainly relieved his rest pain without doing a major surgical bypass. This is one more example where you can see the long tibial balloons here. And in fact, we can go all the way into the foot as well to dilate these arteries. Another example, diabetic 68, rest pain and ischemic ulcer near fifth toe due to shoe bite. He had a multivessel below knee disease, had angioplasty of TP trunk, that is tibia peroneal and posterior tibial artery 6 weeks prior to when he saw me. His rest pain continued, ulcer never healed. His angiography showed stenosis in TP trunk, ATA, PTA were occluded. There was faint dorsalis pedis seen, but he was not willing for another endovascular reconstruction. I took him for exploration of dorsalis pedis so that I could bypass from popliteal to dorsalis pedis. But dorsalis pedis was heavily calcified. There was no lumen, so I had to abandon. So offered him attempt of endo or amputation. And this is where his picture was. You can see the residual TP trunk stenosis here. There's complete cutoff of ATA and PTA. Only peroneal was seen, but even proximal peroneal also was narrow. And so I put a drug-eluting stent, what we use in coronary, in the TP trunk here, as well as ballooning the proximal part of the peroneal. You can see nice peroneal going down all the way. His rest pain was relieved. Ulcers also healed within 2 months of time. So these are the kind of pictures and patients we get. This was referred to me 6 months ago. I'm looking at the foot. I'm sure many of us would say, no, it needs an amputation because extensive necrosis. But from my point of view as a vascular specialist, his heel was good. So we offered him to try and save his limb. He had a basically water spillage, a hot water spillage that formed a blister, and that's how he developed the burns and necrosis, which was debrided. And then after 48 hours, foot looked what I showed earlier and was advised below amputation. So Doppler showed SFA long occlusion, possible TBS disease. We took him for endovascular revascular in view of infected foot. And after revascular, we did a forehand midfoot amputation after revas. And this is a long occlusion. This is a common femoral profunda, but complete occlusion of superficial femoral artery. And it is refilling just above the knee. And this is a long balloon to balloon the artery. And then followed by another bigger balloon, bigger size balloon. This was 5 millimeter balloons. And then followed by a long SFA stent. And this is what we had to do. And this image 1 week ago after the surgery. So we basically did a forehand midfoot amputation, nice bleeding, and a good intact heel. That was at the time of surgery. So bleeding is good, and we encourage us for a good healing. Another non-healing foot ulcers in diabetic foot. He had a nail injury on the right heel at work, and he turned out to be diabetic. He knew his diabetic status, but didn't take any treatment. Developed necrosis of heel, referred to orthopedic, debridement done, no bleeding, ischemia continued. He was advised below an amputation. This is how he presented with an ischemic ulcer on the heel. Now, these are very difficult to heal, but on angiography, it showed multiple stenotic and occlusion of the superficial femoral artery. There's an anteritibial artery, complete occlusion of posterior tibial artery here as well. And there's a diseased posterior tibial artery going into the foot. So we had to open the SFA as well as the tibial artery. So that's an SFA stent here, which is open, and balloon dilatation of posterior tibial artery going all the way into the foot. And this is, so that's a SFA stent, and there's a tibial dilatation. And that's how the picture looked after the angioplasty of the tibial balloon, both anteritibial and posterior tibial feeling nicely coming into the foot. This was 1 week after the debridement, 2 weeks, nice bleeding, very happy. 3rd week, again, after putting VAC for 3 or 4 settings, this is all, it was ready for skin grafting, and that was after skin grafting. So role of vessels are most important because diabetes is a vascular disease. A routine screening for PAD for end organ preservation would be mandatory. Management of peripheral arterial disease with same aggression as in non-diabetics. Major amputations can be avoided in 80 to 85% of diabetic patients by limb bypass or endovascular procedures. End of the day, I would like to say, if there are clinical findings, ABIs, if they're low, ultrasound Doppler showing occlusive disease, you shouldn't consider any amputation without doing an angiogram, and preferably an DSA, followed by intervention or surgery. So limb salvage by peripheral vascular surgery or endovascular intervention should and must be attempted in diabetics with peripheral arterial disease who has a usable heel. So as long as the heel is good, we must try all our attempts to try and save that foot and prevent a major amputations. We have so many tricks up our sleeves, and there are lots of balloons now today we use with drug-eluting kind of things, which are giving us a good results in endovascular procedures. The patient's acceptance and the physician's acceptance undergoing this treatment is much, much better than 15, 20 years ago when they were going long distal bypasses with long incisions. So endovascular, there is an endovascular revolution in managing these multi-segment diseases, and more hardwares are available with better and better long-term patencies. Thank you.
Thank you, sir. I must say, I really love the last bit of cartoon to show the balloons.
Now, Shantanu, may I ask a question?
Yeah,
Yes.
sure. You're most welcome, Alok bhai.
Dr. Kamit,
Yes.
being a diabetic foot surgeon for, I can say, quite a length of time, I appreciate your excellent talk and some really challenging cases done successfully. I have got one query always. How much do you rely on CT angio? As a primary surgeon, when I see the patient, what is the importance of CT angio?
See, in diabetics, most of the times the vessels are calcified.
Yeah, that's why.
So CT angiography is not a good investigation. What I would approach is after clinical examination of the patient, when I suspect there is insufficiency, I would get a color Doppler from one of the guys whom I believe in, because again, Doppler is an operator dependent procedure. A lot of guys can miss out important things. So, so if you have a radiologist who you train, a sonologist, and who is working in tandem with you, then you start relying on those findings. It's a give and take kind of the thing, training wise as well. And if my Doppler tells me where are the likely lesions, then I would straight away go for a DSA with a small 4 French catheter or a sheath inside the femoral arteries, depending on whether it's antegrade or otherwise. And then, with the goal that if I know the Doppler report, so I'm going to open up either superficial femoral artery or tibial in the same setting. So I explain to the patient. So 2 advantages. One, even if they're calcified arteries, DSA is a good measure. Number 2, you are controlling the volume of contrast as well. If you go CT angio, there's a huge volume of contrast. Many of these diabetic patients have a chronic kidney disease, and it's not really suitable. They're creating 1.6, 1.7.
No,
So
that's what I mean to say, because the important message is because CT angio has been overhyped in diabetic patients, which doesn't give us enough information. And as far as planning to shift the patient for DSA, it is just like going for angiography,
Yes.
SOS plasty.
Correct.
So that becomes a bit difficult cost-wise, because at present it's very costly. Now, second question.
Another alternative to that, your question is, many times if I want to decide what is the approach I'm going to take, whether I'm going to take brachial approach, whether I'm going to take retrograde femoral crossover or antegrade femoral approach, I would do MR angio without contrast. So MR angio without contrast will tell us what are the likely lesions. If my Doppler is not very conclusive, then I would do that.
And that's what my guys say. It has got a very long learning curve, MR angio, to comment upon positively or absolutely negatively.
Yes.
Now, second question. In a scenario, how much weightage do you give to microangiopathy element as a vascular surgeon? Because say, for example, if I'm viewing a patient having dorsalis pedis and posterior tibial palpable, but still he has got a toe, a second toe or third toe gangrene, dry gangrene, classical ischemic, maybe because of embolic phenomenon or maybe because of some other phenomena, acute thrombosis. So, like in the macro and microangiopathy, what element do you really feel come across whenever you are dealing with these kind of patients?
Most of the time, as I mentioned, even in my slides, it's a kind of I wouldn't call it a misnomer as a microangiopathy, but many times, there is no thickening of the basement membrane. So even the foot, whenever we're doing angiography of the pedal arteries, we see that those vessels are patent, number 1. Number 2, if you say that ATA, DP, PT palpable, whenever we are doing angio, even we can open those pedal vessels with a smaller balloon, 1 mm balloon or 1.5 mm balloon with special wires. So going into the foot also, what we call as a tarsal angioplasty is now possible because of the availability of the endovascular materials like small balloons and different wires. So even if there's a disease in the foot per se, earlier it was not possible for us to go into the foot and do operate except maybe a lateral plantar artery or a dorsalis pedis in the proximal part, just around the ankle level. But going into the foot, it's possible endovascularly also to open up those vessels.
You mean to say when they are patent, you can palpate, still you would like to go over there and do something? When the dorsalis pedis and posterior tibial are palpable?
So if you have a dorsalis pedis and posterior tibial palpable, you suspect probably there is a foot disease. and a good angiography at least will tell you if there is a narrowing of the arteries in the foot, and generally these narrowings are not a long segment narrowing, they're kind of a very focal narrowings. So it's possible to open even those focal stenosis with a small balloons.
Then that brings my third and last question. Like if the distal honor color Doppler, which is done by a reliable sonologist, okay, you find the lumens are patent, but there is monophasic flow in the vessels. And if you do a proximal procedure, do you find increase in the pulse pressure of these vessels?
So if there is a monophasic flow, that means there is some proximal obstruction.
Yep, that's right.
On a Doppler, many times it is difficult to visualize iliacs and aorta. So in that scenario, it is very likely that the patient may have a hemodynamically significant lesions either in the iliac arteries or probably even the aorta also. And until and unless that is corrected, there is no point opening the arteries in the legs. So that has to be addressed, looked at for any significant stenosis in the iliacs and aorta. Open those first and then go into the leg.
Right, that's what, but the sonography has demonstrated the patency of the lumen of the distal arteries, like dorsal DP and posterior tibial. And if you release all sorts of things at the proximal level, do you really find increase in the pulse pressure at the distal level?
Not really. I mean, sometimes, it may look like the widening of pulse pressure, like how you may see in aortic regurg. But it's not such a common kind of thing, phenomenon we have noticed.
Thank you very much. Thank you, sir.
Anesh, one question to you. You mentioned about routine screening of this patient. So in clinical practice, if a diabetic patient comes to you, what is it that clinically will tell you that this patient should go for a prophylactic DSA or something like that, so that, these guys are going to be definitely high-risk patients?
Mahendra, as you mentioned in your slides, any wound which is not healing beyond 6 weeks.
Yeah, that is once the ulcer.
You suspect that. But clinically, when they come to you, obviously with the clinical examinations, if there are absent pulses, and if there is an initiation of small ulcers, that is the time at least you should get a good color Doppler. And then subject to, now many times what happens, now essentially we are doing this for wound healing. Let's put it this way. Yep. Bottom line is wound healing. So sometimes the patients may not be willing also to undergo such a major things, that they come with ulcer, there is a peripheral vascular insufficiency, there are blockages in popliteal and tibial artery because there are no pulses palpable. Then the way I tell them is that, okay, you go ahead with the debridement. If the wound doesn't heal, then we got to do it. That's, I think, other way of putting it across to them. So if it's a dry gangrene, for example, I always tell my colleagues not to do amputation till we improve the circulation or vascularity. And if required, then they can go for an amputation. Wet gangrene, obviously, you have to do that first to get rid of infection and then do a revascularization. But in the clinical setting, as you asked, if there are no pulses palpable, especially pedals, and again can be difficult in a edematous feet. Again, ABI, ankle brachial index, can show you high positive or high negative because of calcified arteries. So any suspicion, I think first thing is, other than clinical examination, get a color Doppler from a good sonologist. That would tell us how is the vascular flow going into the foot. Any insufficiency, back of your mind, inform your colleague as well that, okay, this is what is that. And even if you do a debridement, there is a likelihood problem that that wound may not heal or it may worsen. And that's when revascularization should be thought about.
Thank you.
Right. One last question, sir. In one of your last examples, you have shown that the heel ulcer has been covered with just a mere split thickness skin graft. But heel being, the heel pad being a special kind of tissue, and a skin grafting, will that be sufficient? Will that not lead to...
No, obviously, this was just to cover the wound and heal the wound, but he would need offloading and all the special feet, special shoes and everything.
Right.
So this was very interesting case because I don't know, the son basically started labeling as an industrial accident, and after the amputation, he would have probably asked for a huge recovery from his owner, and the whole idea was to save the limb, because industrial accident, you are losing a leg, the recovery or recovering money from the owner is huge. But I take your point. Obviously, you would need offloading and special shoes.
Thank you, sir. Your presentation has been a marvelous one, and we are privileged to have witnessed it. Thank you, sir. Thank you very much.
Thank you so much. Thank you.
Thank you. Sir, the next speaker in line is none other than the past president of Foot and Ankle Society, my elder brother, Dr. Balwinder Rana. He has been absolutely vigilant and absolutely working hard in the field of ankle fractures and in diabetics. So his talk, who is ready with his talk? Thank you.
Good morning to all of you, and thank you, Mahendra and Shantanu and IFAS and BOFAS, as well as Maharashtra Orthopedic Association and the organizers for giving me the opportunity to be here. So I'll be talking about ankle fractures in diabetic. So the question is, why should we talk about it? The simple fact is that there are higher complications rate in diabetic patients. We conserve them or we operate them. There is a problem with diabetics having ankle fractures. I'll just refer you to one study. There are a number of other studies which tell us about the results of ankle fractures in diabetic patients. But this was a large database studies of 10 years patients in California. And they had a huge number of patients, almost 57,000 total ankle fractures, out of which about 4,000 were uncomplicated diabetes and about 1,200 were complicated diabetes. And you see the odds ratio of developing an infection in a diabetic patient, which is a complicated diabetic, is almost 4% as compared to a normal patient. And the risk of having an amputation is 27 times more than a patient with an ankle fracture who's a non-diabetic. So that much damage a diabetic ankle fracture can do. Even in an uncomplicated diabetic ankle fracture, the chances of having an amputation, a below-knee amputation, compared to a non-diabetic ankle fracture is almost 6.41%. And look at the high number of infection rates and revision surgeries needed in diabetic fractures, diabetic ankle fractures. So it's an important topic. Obviously, there are some things which we are missing, or maybe obviously diabetes itself is a very big factor. So what I'll do is I'll show you a few examples, and by way of those, maybe some things to take home, what should be done and what should not be done. 60-year-old controlled diabetic. This is on day 2 of fractures. It's a controlled diabetic lady. You can see that there is a trimalleolar fracture, comminuted fracture of the lateral malleolus, medial malleolus, posterior malleolus. And this is how it was fixed. This is 4 weeks after surgery. The fibula was fixed with a 3.5 recon plate, tension band wiring on the medial side. The posterior malleolus was ignored, and the ankle was mobilized at 3 weeks, and weight bearing was attempted at 6 weeks. But at 4 weeks itself, it was starting to move. So we could see that there is a lateral subluxation of the talus. The medial gap or the medial clear space is more, and there appears to be a shortening of the fibula. So this had to be revised, removed the medial tension band wiring, and we did the replacement of the middle screws of the lateral plate with syndesmotic screws, reducing the talus onto the medial side. For various reasons, we did not go onto the medial side to fix the malleolus again and the posterior side again, because the patient was not willing for a significant amount of intervention. So these are protibial screws. These are called protibial screws. The message here is that in comminuted fibular fractures in diabetics, in complicated diabetes specifically, we should use longer plates, stronger plates, more screws, and maybe protibial fibular screws. And the period of immobilization has to be much more than the usual non-diabetic ankle fractures. So that is the first message. Then we have certain situations like this, where this patient came to us at 3 weeks post-injury, 50-year-old, uncontrolled diabetic. He was treated outside in a smaller town, and he was told that he has a minor chip fracture in the ankle. He was put on a slab for about 10 days, and then he was asked to remove the slab and walk on it. When he removed the slab, there were a lot of inflammation, swelling, redness, and tenderness. Obviously, the skin was shiny. So the treating orthopedic surgeon thought that it's an infection, and he was started on IV antibiotics after removal of the slab and cast, whatever he was on. And then he came to us walking in the OPD at 3 weeks with this picture. Obviously, we did an X-ray, and it was not a minor fracture. Somehow or the other, it was a displaced medial malleolus, completely proximally migrated, and it was now also associated with a talus fracture and possibly a subtalar fracture also. He had an uncontrolled diabetes. HbA1c was 11.5, random sugars were high, his counts were normal, inflammatory markers were normal, Doppler was fine. Obviously, he had evidence of neuropathy on clinical examination on the opposite foot also. CT was obviously, as we discussed, medial malleolus comminuted fracture. The talus body, parts of it were extruded medially through the medial malleolus fracture. So we controlled the sugar on insulin, and in about 3 days, we went in and did an exploration with the anteromedial approach and found a non-reconstructible fragments of bone, talus as well as the distal tibial fractures lying all over the place. They were not reconstructible. And at that time, this was a long time ago, did not have TTC fusion nails. In today's time, I would have just put a nail in this. Because of the comminution, we're not happy with one plate. We went on to the lateral side, did a transfibular approach and put on dual plates, one medial and lateral, and 10 weeks it healed. But unfortunately, 9 months post-surgery, this patient had a fracture. This time the plan was to remove the plates. Proximal to the tibia, there was a fracture in the tibia, but the plates were cold welded. These locking plates could not be removed. And so we had to go in and do something which we would not want to do, a plate onto the proximal side. And then fortunately for us, I would say we were fortunate in this patient, this did heal and the patient was ambulatory. Another example of a 55-year-old male, which an HbA1c of 9.8, nephropathy, neuropathy, and this is at about 4 weeks post-injury. So would you like to conserve this? It obviously doesn't seem like a easily reconstructible fracture, and with the complications of nephropathy and neuropathy already there, we opted for a transfibular approach and did an ankle fusion. Another example of a 60-year-old male presented to us at 10 weeks with this X-ray at the end of 10 weeks, treated conservatively in a cast elsewhere. Seemed that the fibula had united, but on clinical examination, unfortunately, I don't have the picture. He had a valgus deformity, and whenever he was putting weight, the ankle was subluxing into valgus. And on closer inspection of the X-ray, we thought that the talus body had some radiolucent line there subchondrally. So we did a CT scan, and truly there were non-union of the fractures of the fibula also, medial side also. There was a small posterior malleolus also, and the talus was already getting disorganized. So this was an ankle fracture, which due to early weight bearing led to more comminution in the softer bone. It was a Charcot's now getting established. So again, we did a transfibular approach, did an ankle fusion with multiple screws, and that's about 5 months post-surgery, and this healed, and the patient is walking now without problem. So the learning points here would be that a bad ankle fracture in a diabetic neuropathy may end up in a fusion. So why not consider a primary fusion in some of these patients where the fractures are bad and the diabetes is complicated. Another case, this is 4 days post a closed fracture where the patient was an undisplaced fibular fracture initially. Patient was put on a cast and was asked to walk. That is the dictum that we follow in an undisplaced lateral malleolus fracture. In a non-diabetic patient, we put them in a cast and ask them to walk, or even in a boot, we ask them to walk. But this was a diabetic uncontrolled patient, and he was put in a cast, asked to walk, and this is how he presented to us on day 4. It was a closed fracture on the time of presentation, on the time of initial injury. This side is a great toe, and that is the medial malleolus now coming out through the wound. So that's the medial malleolus through the wound, and this side is the toes. That was his picture to us at the time of presentation. This medial malleolus had come out of the wound and it was already infected, foul-smelling discharge. We put him on a joint spanning frame. Even on the frame, this was extremely unstable, and we would not do it usually, but put through axial pins to stabilize the ankle in some position. We could do that, And after a period of time and dressings in the external fixator, the wound seemed to be healthy. We removed the fixator and put him in a below-knee cast for a period of time. We intended to carry on for about at least 4 to 5 months before allowing him to weight bear. Now, in between, something happened. This patient landed up in emergency just one fine day with exuding pus, and he was in septic shock within 24 hours. And then he ended up, eventually after 3 surgeries, ended up with a below-knee amputation. So neuropathics may walk on their ankle fractures. Be aware of that. They don't have sensations. Closed fractures in these patients because of loss of sensation can become compound. And if they develop an infection, diabetics and neuropathy is a very high rate of amputation. Is there any guide in the literature? Well, there are very few. I found this one, which I sometimes refer to, what to do in a diabetic ankle fracture if you have an ankle fracture. Now, they have identified certain parameters to which they give some points, like peripheral neuropathy, loss of sensations, vasculopathy, history of Charcot's in any joints, whether the diabetic is insulin dependent, and whether the control is good, decided upon based on HbA1c levels being more than 7.5 or less than 7.5, and 2 points for each of these and 1 point for each of the parameters on the right side. And with that, if you have a fracture dislocation of the ankle in a diabetic and it requires a fixation, and you calculate the score and the score is more than 5, then it is suggested by these authors to consider primary orthodesis in these patients instead of open reduction internal fixation. But if the patient is already in the Charcot stage, then assess the staging and then conserve them in case they are in stage 1, and then follow them up over a period of time to decide about fusions later date. So the message is that fractures in uncontrolled diabetics behave differently as compared to non-diabetics or diabetics with well-controlled diabetic. In diabetics, we should then ask for history of neuropathy and examine for a sensory loss in all patients with monofilaments. If there is any doubt, we should do electrophysiological studies of the nerve. And in diabetics, if we operate upon them, they need more of everything. They need more investigations for neuropathy. They need Doppler CTs for circulations, for defining the fracture more clearly, for longer durations of immobilization, longer durations of non-weight bearing, more fixation, stronger implants, and some of the neuropathic diabetic ankle fractures may require primary fusions. Thank you very much.
Palvinder, that was a very nice presentation. Can I ask you a question? So
yes.
when you have such patients coming to your clinic primarily, how do you counsel them? Because we can't predict who is going to get into what stage. So do you counsel them about all the complications on day 1, or you deal with them as it comes? Because these patients can sometimes become extremely. When I had a patient just 2 months back, and ultimately landed with amputation. Very, very difficult to predict who's going to get into what situation. So how do you counsel them? And that's a very, very relevant question in private practice.
Yeah, I agree, Mahendra. So I am very upfront about the possible complications in diabetics if they are uncontrolled and they have comorbidities, as well as they have complications of diabetes like nephropathy and neuropathy. Then I'm very, very upfront about them. Even if the initial fracture is looking innocuous on the x-rays, I tell them that this is not a benign fracture and this may end up in a number of complications. So I tell them and I document it. On my first consultation, I write down everything that I've discussed with the patient. Well, some of them are shaken, but then that's what it is. And I think proper information has to be passed through to the patients that a number of things can go wrong in a diabetic ankle fracture.
Do you immobilize them into station in a cast boot for what, 3 months, 4 months?
After surgery?
Yeah, post surgery, once everything is healed.
Well, it would depend upon whether the diabetes is complicated or controlled. If it is an uncomplicated controlled diabetic, I would treat them as any other ankle fracture unless the bones are really osteoporotic. So, but if they are uncomplicated and very well controlled diabetics, then generally we mobilize them early and put them in a splint or a brace for about a couple of weeks to 3 weeks and start mobilizing. them early. But I will still delay the weight bearing part of it. Even if it is a controlled diabetic, I will still delay the weight bearing for about 2 to 2.5 months. While if it is a complicated diabetes with a number of other complications, then I would put them in a plaster for at least 6 weeks after surgery also, and then I will not allow them to weight bear for a minimum period of 3 months. And sometimes that can extend if the patient has come a bit late and it's a bad fracture with a lot of osteoporosis, then that period of non-weight bearing I can extend to more than 3 months also, unless I'm really convinced that it is solidly united before allowing them to walk. And when they start to walk, I would put them in a brace of some kind, like a boot or something, and then ask them to slowly progress, which is not easy to do for them because most of them are old patients and they don't have the strength to do a non-weight bearing or a partial weight bearing, but that is the advice that we give them. If possible, they should do it.
So when you say that it is complicated diabetes, I think the point we should make is that it is the neuropathy that is more dangerous, or equally dangerous as vis-a-vis a good glycemic control. Because these are the neuropathy patients which are the ones who are going to, buckle down under pressure. I think the key is the neuropathy that is associated with all these patients, our majority of them.
Yeah, so number of factors were recognized in the study that I quoted. So they recognize a number of factors to define what they call as a complicated diabetes. Neuropathy is on the top of the list, as you suggest, but nephropathy, cardiac complications, as well as retinopathy also comes into focus. Although neuropathy is the thing that we are really scared about. Yes.
Thank you.
Right, Dr. Mohanty sir has a comment to make. Dr. Mohanty sir.
Yeah, excellent lecture, Dr. Balvinder.
Thank you, Dr. Mohanty.
Recently means the last couple of months, 2 patients of diabetic neuropathy presenting with ankle fractures, we have fused them primarily. And especially 2 months back, one lady had come was uncontrolled diabetes with a 3 weeks old ankle fracture. And we went through the literature, the sensations were not there. So we fused, but we fused with tibia talocalcaneal nail, the TTC nail, where you fuse the ankle as well as the subtalar joint. So then we had put plaster and then it has healed. That expecting that after fixation it may proceed towards a neuropathic joint, because the origin of neuropathic joint is always a minor injury or minor trauma giving like to osteochondral fractures, and that leads to diabetic neuropathy. Then it becomes sarcose joint, and it's very difficult to treat the sarcose joint. My question to you that do you have any indication of fusing only ankle joint, or do you do also ankle along with the subtalar joint fusion?
Well, I don't think there are any definite clear guidelines whether you should be doing a TTC fusion or a pure ankle fusion if you are treating an ankle fracture primarily with a fusion. I would do a TTC nail if the neuropathy is really bad, and if a patient is presenting a little late with already signs of Charcot's established. Then obviously a TTC is definitely the best option. But if it's an acute fracture is not a Charcot's per se at the moment, and the patient is not, the fracture pattern is not that complicated, it's not really accommodated or a dislocated talus, then we can get away with doing just maybe an ankle fusion. A lot of factors will come into focus if you want to make that kind of decision. It's not easy to say that this is better than the other, but a hindfoot nailing is definitely a very good option, especially if a patient has a limited mobility and is not really active and a really complicated fracture, presenting a little late, and a bad fracture. So I think nailing then in that situation would be a better option.
Balvinder, may I? We have got experience of recently, means in last year only 2 or 3 patients who came to us walking with the trimalleolar fractures.
Yeah.
Now the patient who has come walking with a trimalleolar and subluxating ankle, on day 1 it was decided that it has to be fused. It cannot be reconstructed. That is one criteria on which we have done 3 cases, primary fusion. Because if he can walk on the day 1 without any problem, he has got significant neuropathy, and that case is likely to deteriorate. That was an excellent talk. Thank you.
Thank you, Alok. Thank you.
Right. Yeah, Dr. Pradeep, please.
So again, answering, sorry, part of that talk and a part of the question probably goes into the hindfoot fusion. That's why I thought I'll just answer and add something to what Dr. Mohanty sir has asked. So I think, yes, I don't think so. As Balwinder has said, there is any studies looking for acute ankle fractures or say within that 6 weeks gap, within the 6 weeks post-op where you either a pure ankle fusion or a TTC nail is an option. But I would just want to add that I have seen quite a few people doing TTC fusion or TTC nail for ankle fractures, but they do not prepare the subtalar joint. I don't think so. That's correct. And I will show you in my presentations, in my talk, where people have turned up, where they have failed at the subtalar joint and the nail has broken there. So I just wanted to add a comment on that. So if you do preparing a TTC, if you do put a TTC, prepare the subtalar joint.
Yes.
That's a very valid point, Pradeep. And naturally, fusion to occur in any joint, you have to just remove the cartilage and prepare the joint for fusion. Absolutely, you're right. So actually, you happen to be our next speaker. So let me welcome you, one of our most academic, most versatile, most bright, rather brightest member of IFAS, Dr. Pradeep Manu.
Thank you very much. I would like to thank Indian Foot and Ankle Society, both Mahendra and Shantanu, very good friends of ours. And of course, the Momentum team, both the president and the co-chairman, for inviting me for this talk. So I'll be talking on hindfoot fusion for Charcot neuropathy. Just start with a case. Is a 55-year-old lady, long-standing diabetic, difficulty in walking, no pain, it's just instability and a small wound. And you can see how she's been bearing weight on the lateral side, and she's got this small, you can say a callosity, but of course underneath there would be a small wound as well. And these are the X-ray which you have, and you can find out, see, the talus is in the lateral gutter, completely dislocated or sublux hindfoot. What would you do? How do you manage this ankle? So the goals of any hindfoot management of a Charcot is to restore the alignment and the stability of the foot so that the whole hindfoot or the limb can be braceable, can be plantigrade, can be a stable foot, so the patient can walk on it. However, before we go ahead with doing any surgical intervention, there are some certain contraindications which we need to know. Of course, if there's an active florid infection of either the soft tissue or the bone, or if in the acute stage, or I can stage 1 of the Hall's stage, uncontrolled diabetes, I think previous speakers have already spoken a lot about that. Insufficient bone stock, where you cannot fix anything. You put a nail, but there is nothing to hold either in the proximal or the distal aspect. And the last thing, and this is very, very important, is inability for patients to comply. So patients whom I do advise surgery, I do mention to them that they need to follow all my instructions, the post-op instructions, for at least 6 months to a year. And if they cannot do that, it is better not to operate on them because to avoid a surgical disaster. So patients like this, where there is hardly anything to hold in the distal aspect. The key thing is, especially we have seen in the previous speakers, and I will show us, these are not easy cases. Okay, these are patients whom you inherit from your colleagues, or they come directly to you with either a secondary or a tertiary opinions. And these are high demand patients because there's a lot of both medical management and surgical management. So you could either avoid doing surgeries, but I think these are patients where surgical intervention is required, because amputation is not the answer. And we've seen from both the vascular surgeon and the diabetic foot surgeon, where we know the fact that these patients within 5 years, if we have a one amputation, within 5 years they have a second amputation. You cannot have a bilateral below-knee, above-knee amputation. The mobility is just horrendous. So these are worthwhile getting the patients, inheriting the patients, and operating on those patients. Now, if you're doing a hindfoot fusion, what is the position which you're looking at? You're looking at a neutral or a slight dorsiflexion in the sagittal plane. You're looking at a neutral or a slight calcaneum valgus in the frontal plane, and a little bit of external rotation in the transverse plane. That's the position you should be looking at. Of course, you should be looking at the whole limb in toto as well. So how do you achieve a hindfoot fusion? Cast or a brace, you can use it. External fixators or ring fixators. IM nail, which has really increased in the last 5 to 10 years all over the world. And recently people have started using plates and screws as well. And I'll touch base on these as well. But before you go and operate on these, if you have a patient with an open wounds, so like this patient of mine who came with an acute Charcot, somebody thought this was a cellulitis and had completely a fasciotomy done. Now this came from an closed Charcot, it became an open Charcot. And we had to first make sure that this gets settled down, and then you can treat them surgically. Also, the key thing to understand is when you have ulcers, you have to understand, is this an infective ulcer or a non-infective ulcer? It is very important to determine that, because if it's a non-infective ulcer, you could still go ahead and do an internal fixation as well. And also, as a complete management of the patient, you want to make sure your infection is a control, your diabetes is managed well as well. So looking at the first option, is brace or a cast an option? Of course, there is an option. If the patient comes in very initial stage of your Charcot, and if it's warm, swollen limb, you want to make sure you protect them, you make them immobilized, you put them in a cast, so everything settles down. There's too much of swelling, the whole swelling will settle down. So I put these patients in a complete plaster, and within 10 days they come back, sir, it's become completely loose. Ye both loose ho gaya hai, and you change them and you keep them repetitive till two things: there's further swelling doesn't go down, the skin temperature less than 2 degrees, that's not there as well. And also it buys you time, because when you immobilize the patient, one is you check for the compliance of the patient, and second thing is the body starts throwing bone, so you can work with more bone when you do an internal fixation as well. So there is a definite role in the early stages as well. Now the second most common thing, especially between reconstructive surgeons, who like to do a lot of Elizaro's external fixator or an hindfoot nail, which is better for Charcot. So paper from American Foot and Ankle Society 2016, 27 patients treated by a single surgeon with either IM nail, which was in 16, and a ring fixator in 11 patients. A good follow-up, almost 3.5 years of follow-up. What they found was a limb salvage was in ring fixator was 9 out of 11, while 15 out of 16 patients in IM group, you could salvage the limb. But they found that 7 patients in the intramedullary group at almost 4 months developed some sort of a deep infection, while in ring fixator group, only 1 patient required surgery. So all in all, patients did reasonably well in both groups, but the IM nail group had more complications. The patient, another study from the Journal of Foot and Ankle Surgery 2016, again single patient surgery, single surgeon series, 27 patients, 14 from Elizaro, 13 from the nail group, and they found that the complication rate here was more in the external fixator group than in the nail group. So complications are seen in both. It really depends what you're comfortable with and how you choose your patient and how you counsel your patients. Looking at plates, yes, you can use different types of plates. You have a posterior plate, which you can do through your trans Achilles tendon approach. You can do a lateral plate. You can do an anterior plate. The problem with, especially with the anterior plates, is a skin issue. Lateral plates, you need special lateral plates or long plates, or you could use a Philos plate. But again, wound complications are slightly higher. I could not find any substantial or major good series for this in Charcot. Now, if you're doing a surgical technique for intramedullary lead, I'm just going to talk a little bit on that. You could do it in different positions. You could do it in a supine position. You could do it in a floppy lateral or lateral position, or a prone position as well. If you look at all the manual surgical manuals from the device companies, they advocate a prone position. It's just easier to pass your posterior screws as well. I like to do it in supine. It just gives me the alignment, my naked eye alignment. I am quite good at it, so I like it in supine, but both are equally good. Incisions depend really on the prior incisions, if there is any previous hardware, if you have any flap or skin tissue, skin cover is an issue, and if you're doing a bone graft as well. Really need to plan your incisions properly. The most common incisions used for hindfoot fusions for nails is either a extensive lateral approach, or if you don't have too much of bone loss, then you could use an anterior incision and a sinus tarsi. Both are equally good. Depending on the implant choice, do you use a straight nail or you use a curved nail? Straight nail, it's just ease of use. There's no excessive valgus present. But you know the fact, if you use a straight nail, your entry point is slightly medial, damage to the nerve can be slightly higher. And they also talk about a blowout on the medial side. So you could be skipping the whole medial calcaneum tuberosity and straight away go into the talus. So bearing in mind, especially when you're taking your x-rays, just check that. Curved nail reduces the damage. Here you can see your entry point for the curved nail, and that's your lateral plantar neurovascular bundle. So it's that close. So the curved nail reduces the chance for damage to the neurovascular bundle as well. Now, as I was talking about this, do you prepare the subtalar joint or not? So this is Michael Dogella, a friend of ours, who published in 2017. And this was a series where they have not included Charcot patient, and still they found that the 23% incidence of non-union of the subtalar joint in retrograde TTC fusions. So that's why I would say it is not a very innocuous thing. If you're doing a TTC, do prepare the subtalar joint. And this is one of my case where, in spite of preparation of the ankle and the subtalar, you still had a subtalar non-union and breakage at the subtalar joint. Surgical technique is just a small video which I'm going to show on a 72-year-old diabetic lady with inability to stand and walk, came in a wheelchair. She had exhausted all the conservative treatment. You can see how significant swelling on the lateral side, like a bulb of this is not just Charcot fluid, which I call it. There's a lot of soft tissue as well in that lateral gutter, and you will see how unstable she is. And a varus ankle. Look at that. No talus in the lateral gutter, completely dislocated or subluxed ankle on the medial side. And the body is trying to throw some bone here. So supine, as I said, a supine position with the ipsilateral sandbag. I like it. Open up on the lateral side, go right down. So you can see both the ankle and the sinus tarsi here. Here I almost, as soon as I opened up, I did not take the fibula out because there was so much of laxities. The tissues are all stretched out. I didn't need to take out the fibula. That's the talus, which I'm going to just take it out, holding with a coccus. And I have asked one of my assistants to make sure to hold, because I'm not going to discard this talus. So once that, look at the amount of gap or the bone loss which is there. This takes a lot of time where you need to remove all the shark or the fibrous tissue from the ankle joint and the subtalar joint. Once that's been done, you make sure you get a good reduction. Once you get the good reduction, put a hind foot, put the guide wire from the set. Here you can do it directly under vision. What I do is I do a transmalleolar line, and then lateral part of the second toe, I drop it down, and where it intersects, I put the guide wire. So you can see under direct vision that it is coming into the center of the calcaneum, not center, but slightly more anterior as well. You can come. Once you have done that, make sure you see the distal tibia, and then you can reduce it and fix it. Put another guide wire to hold the whole hind foot in the alignment which you wanted. Check it under CM that it should be in the center, both in the AP and lateral. And then you ream it. You should ream it, and you should pass through the isthmus. If it is a normal fractures or normal TTC nail, you can get away with a short nail, but in Charcot, I would not advise. So these different companies would have a 150, 160. These probably nails, I would not use it for Charcot. So minimum, I would use it at least 180 or 200. Not too long as well, I would go. Because if you go too long, and it really needs to go in the upper part of the tibia, and if you're slightly off in your calcaneum, it will throw off your whole alignment. So just beware of that. So I would go just proximal to the isthmus. So here I'm using the talus and splitting it and using that as a bone graft and filling the gap which I have already shown. Also, I took iliac crest as well. So all my patients, especially with these very unstable patients, I always prepare the iliac crest for bone graft. And there are multiple studies which have shown that autogenous bone graft is much better than allograft. Allograft takes a very long time to heal and ooze as well. So many times you don't know if these patients have ooze because of your autograft or is it infection. And especially in diabetics, I've tried to avoid using allografts. So here 3 distal screws, 1 proximal screw. I was quite happy with that. Proximal, I use a dynamic, and of course, because I've used a long nail, it goes through the isthmus, so that also gives a decent stability as well. Once that's been done, post-op, I protect them for almost 3 months in a cast, and then gradually I make them weight bear. I don't know what happened there. And that's the movement we can see. So just another case. So here I have used a curved nail, and you see how you can, the point of entry or entry point is slightly lateral and gives a good fixation as well. And the other thing of hindfoot fusion, use a nail which you gives in a 3-dimensional stability. That's another important thing which you should be doing. My personal series of Charcot, we have had more than 55 cases. If of that 34 I've done of hindfoot fusions as well in this. And these are the different types of cases we've gone across. Sometimes you have minimal bone loss and sometimes a significant bone loss. Here you can see the calcaneum is almost gone as well. So open Charcot, I mentioned, I put them in an axial fixator, make sure the wound heals, and then you can treat them accordingly. So coming to the case which we discussed earlier, that lady, that's the kind of thing. I did a debridement, put in an axial fixator, let it heal, and then put a hindfoot nail. Once I'd done that, this is a year down the lane. She did very well, healed completely. And she was quite safe walking, well aligned. Another patient, 74-year-old male, significant hindfoot valgus, Charcot, pre-op, post-op. There you can see completely gone, bone loss. So I here use the fibula, take it out as much as you can, fill up the bone graft. Hindfoot height should be maintained or elevated or raised, so the leverage arm is better. And then that is 1 year post-op, walking. He just uses an occasional stick when he is going out, and he can almost walk almost 10 kilometers a day. Another case, distal tibia, presented 2 months down the line, diabetic, and he was walking on this. So the plan was initially either do a fixation with a distal tibia, but when I pulled it out, I thought I could not get any fixation on the distal fragment. So it planned for a nail, and it did quite well. So in my series, follow-up has been from 6 months to 48 months. I have been able to achieve bone or fibrous union in most of these cases. Average time to union is almost 4 months. Ulcers, if they have managed with an external fixator. Of course, you do have your complications do occur in every patient series, in every person series. I had 3 infections which required nail removal, and you try to initially manage with debridement, but finally, if it is intramedullary infection, you do need to remove it. But ultimately, they do go into a fibrous plantigrade braceable foot, which is, I think, still a positive and a good outcome. Another thing, especially in my initial days here, intraoperative, if you do not ream it properly, you can have this. This patient had a periprosthetic fracture intraop. I did not recognize it. Post-op, I saw it, protected him for around 4 months in a plaster, went on to heal very well. Another patient, so this is an interesting case. Again, he had a wound. So I put in an external fixator, put this nail. He came back almost 4-5 months later with a slight swelling and a bump happening here. And you can see even in the plaster, he was walking, periprosthetic fracture developing. And this is the hole from the external fixator. And initially, I tried to think that he would be managed in the cast, but he was going into recurvatum. So I changed into a longer nail and healed quite well. So another, these are implant related. So especially this is a trigen nail, and the talocalcaneum screw, which is at quite an oblique angle, and I do it in supine. So I find that's slightly difficult to put. I had a broken drill. Always make sure this screw, the talocalcaneum screw, goes through the nail. You don't want to have surprises like this as well. So in summary, Charcot's, I divide into ulcerated or non-ulcerated. If it is ulcerated, put in a fixator for 6 to 8 weeks, make into a closed Charcot and treat him as a closed Charcot. Aim is to achieve a stable plantigrade foot, and for an ankle, I do a nail, and for foot, somebody else will cover that. So take home message is internal fixation works quite well, but they need to be counseled properly, need immobilization for longer period of time, does increase your union rate and reduces your complications rate. Thank you very much.
Thank you, Pradeep. That was a wonderful presentation. Now,
Shantanu, may I ask?
Yeah, please go ahead.
Pradeep, it was a very nice and very long series. I had just a limited experience of around 7 cases. And in the last 3 cases, like one you shown or last two cases where you saw periprosthetic fracture. So in last 3 cases, and like you specifically mentioned that you are not willing to go up to tibial tuberosity, I had discussion with many guys and a few stalwarts of our field. And ultimately, I decided to go for a 300 mm nail at least so that I can reach up to the tuberosity and just locking only one dynamic hole, never lock the proximal most hole. And I had to face one complication, fortunately for me. So like one case where you increase the length of the tibia, the nail, to you revise the nail. Now again, the height, it's just crossing around 1.5 inches more than the previous nail. So don't you think again it will be a stressizer at that level? So what problem exactly do you feel once you have reamed the canal? What problem exactly do you feel in the 300 mm nail and reaching up to the tibial tuberosity?
So I think it's a very good question. And high side, I think for the one case where I have revised it for a late periprosthetic fracture, I think the cause was I had put in an external fixator. So one of the pin sites was just at the tip of my nail, and that's where the fracture happened. Now I put in a long nail, and this was the Smith & Nephew, the longest nail which I could have. And yes, ideally you would want to cross 2 cortical width beyond the stress riser, but this was the longest. So I crossed my fingers, protected him for 6 months. So one more thing is you should protect these people as long as it is possible. They really come back and say, doctor.
Hello, can you hear me? Yeah, one more thing which I saw, I add on few more screws from say tibiotalar or tibiotalo-calcanean, even up to the. So 1 or 2 screws addition after putting the nail, that has probably even also given me some.
So I have seen people doing that, but I don't do it because I find after you have put your nail, and which is usually a 10 or a 12 in your calcaneum and your talus, you don't have much bone to play. So yes, you could on your X-ray see that your screws are there around your nail, but I don't know how much hold you get. So yes, you could be mentally happy with your X-ray, but if you get a good hold, fantastic. But invariably, I find that there is not much of bone to play.
Okay. And as far as this removal of any, do you think when do you plan or do you ever remove the dynamic screw or the other proximal screws of the tibia?
So proximally, I've always put 1 screw dynamic hole. That's it. I don't use 2 holes.
Do you remove it?
No, I don't.
Because one thing again, I had a discussion that if you remove it, you again reduce the stress over the tip of the nail. If you remove that screw, so it helps in preventing probably preventing a stress fracture again in the proximal line. That's what my limited experience is. Though I have to go a long way. Yeah.
Very good, sir. Very good.
Thank you.
Thank you. Thank you so much.
Yeah. Question from my side. How long do you immobilize these patients in a cast?
At least 3 months, sir. At least 3 months, and then give them a walker boot for at least 3 months to 6 months. So my opening statement before I plan for surgery and before counseling is, you need to give me your 9 months of your life, and you will do exactly what I tell you. If you cannot follow instructions, I would not touch them, because you don't want patients coming up at 6 weeks, sir, can I walk now? Can I give this up? Because though it is an intramedullary device, though we talk it is a load sharing device, Charcot is a completely different kettle of fish, sir.
They require long period of immobilization. That's
yes, and of course all the other things as well. So you need alendronates, you need teriparatides, you need all the other supplements as well.
Yeah. I think I suggest that you should publish these 55 cases outcome.
Sure.
Yeah.
Thank you.
Thank you.
Yeah, thank you, Pradeep. The one thing that you mentioned at the end and also at the beginning of your talk is the patient counseling. So you should always take a patient who is willing to abide by your treatment plan. So that was a wonderful thing to mention. Thank you so much.
Thank you.
Taking the webinar forward, it is my, again, proud privilege to welcome Siddharth Sharma, Dr. Siddharth Sharma, who is an associate professor at one of the premier institute of India, the PGI Chandigarh. And he shall be showing why an ankle fracture in a diabetic is different from an ankle fracture in a normal person. Dr. Siddharth Sharma, please.
Thank you, Dr. Shantanu, and my highest regards and thanks to the organizers of this wonderful event. We've heard some great talks. And Dr. Shantanu, if I may, can I take this as a one-on-one case discussion with the faculty? I believe that would be more interactive.
Absolutely. Go right ahead.
Okay. So Dr. Balwinder showed a wonderful talk why ankle fractures in diabetics are very different. And this is just, something to take it forward. So this person comes in with a road traffic accident. He is a 50-year-old male cop, and he tried to stop guys on a car to check their license. This is not the actual footage, but this is something what happened. And mind you, because he did not come initially, I did not have his X-ray, but now you have a 50-year-old with a type 2 diabetes mellitus of 10 years duration, controlled on oral hypoglycemic agents. He is doing well, has no other comorbidities, except for this fracture. The sensations and pulses were intact to begin with, and he had swelling. And I am again sorry, I don't have the initial X-rays, but I tried to draw this. And Dr. Shantanu, looking at these images, what would be your plan if this came to you?
Well, if the patient were not diabetic, I will definitely go for open reduction internal fixation. I'll do a proper imaging of the patient, maybe get a CT scan done, 3D CT scan also. And as soon as the swelling subsides and permits, so maybe if the swelling is too much, initial spanning of the fracture, and then CT scan, then planning the definitive fixation. And then I'll fix all the
So, sir, what would be your definitive fixation plan for this case, sir?
Maybe a plate for the fibula, or an screws or tension band wiring for medial malleolus, and a plate and a buttress plate for posterior malleolus.
Okay. So actually, sir, in this case, it was a Chaput fragment. It was a Chaput and anterolateral fragment with, but you are right. He has a sort of, I would not call it a trimal.
No, it is not. I'm sorry. Yeah, it is a Chaput anterior fragment. Yeah.
It is an anterior fragment, and the ideal way to fix it is to address all three components, because the syndesmotic instability in this case would arise from the Chaput part of that fragment. So yes, we already discussed this. So like I said, this was not managed initially by us. So the index surgeon waited for 7 days, like you said, in a slab. They waited for the swelling to come down, and they planned for fixation. And this was the immediate post-operative X-ray. And can I have Dr. Pradeep, sir, your comments on this fixation, sir? This was the immediate post-operative X-ray.
What do you want me to tell you, Siddharth?
No, sir. So again, this is not nitpicking or finger pointing, but just what happened, what went wrong, and how this could have been prevented.
So I think the key thing is, as I'm sure previous speaker said, we need to get a CT done to understand operatively CT done to understand where the fragments are and fix them. Here, of course, the surgeon tried to get the length back, and I think the fibular side, he did get the length back. The medial side also fixation is reasonable, but the main thing was the anterior fragment, and the ankle is subluxed, and that's the most important part of it now.
So because
sir, may I interrupt you for a while, just for a while?
Please, sir. Yes, sir.
It was initially, with all due respect, it was a less information provided. Second thing, now if there is this piece, whatever is missing in your drawing, original drawing, I saw posterior malleolus, while here it's not apparent.
Sir, I think I made the.
Sorry, sorry. It was an interior Chaput fragment. Okay. Yeah. So if you go back to all the three columns were not addressed at all, the syndesmosis is mal-reduced, and that ankle was found to be unstable.
Yeah.
Though the screw was passed. So that is what has happened probably.
Agreed, sir. Agreed. So because the chaput was not addressed, the anterolateral instability persisted, and this is what we had. So, sir, any idea what you would do now? This is, a few days down the line, and what would you do now with this kind of an X-ray?
If it's a few days down the line, because even the fibula is also looking rotated, mal-rotated, it's looking externally rotated, the chaput is missed, the ankle is dislocated, and is a diabetic still, you can try to preserve it because the initial surgery was done. You have to anatomically reduce, open the syndesmosis, put the chaput back, then realign the fibula, and then medial malleus scan may do fine on table. That's all. We check the stability and put on a multiple or few more syndesmosis, tibiofibular screws or fibulotibial screws.
Right, sir. So I would agree with that plan, because there is no way down the line we would leave an ankle like this. But the surgeon tried to attempt a closed reduction of the ankle.
Yeah.
And, so after the closed reduction, nothing changed much. So it's just that one X-ray is facing on the right and the other to the left. Nothing changed. So now that this has failed, when we do agree that you need to revise the open reduction internal fixation, and Caesar said you clinch the day, you conquer the day, go in with all that you can. But this surgeon, unfortunately, for reasons best known to them, didn't do anything. And 8 months later, this is how the patient presents to us. So Alok sir, at this point of time, inputs from you, sir. So that window of opportunity for us has passed, and what would we do now?
Now you can see the ankle is destroyed. We can call it destroyed. The chaput prevented in the anterior portion, or rather it's turning into a neuroorthopathic joint instead now. And the fibula has though united. You have got no option left except to fuse this joint.
So sir, these are the options. Would you do an ankle fusion, a pan-talar fusion, or refer it to Dr. Pradeep, perhaps? He said.
Pradeep has the longest series. So as far as I am concerned, in this case, if you go back to your slide again, because I had the least time to have a look at it. See now, the ankle is still dislocated. The whole of the tibia has gone posteriorly. You can attempt the subtalar looks radiologically fine, but in a diabetic, I have got a feeling, personal opinion now, that I prefer intramedullary implant over these 1 or 2 plates on the medial or other 3 screws. So my cup will be to do a TTC on day 1, stabilizing the whole complex as a whole and putting in the implant which will serve us for long, with less chances of failure.
I believe Dr. Shantanu had something to say, sir.
Yeah, I just would say that I would agree that rather than putting plates, I'll put something intramedullary and TTC nail with a proper preparation of not only the ankle joint but the subtalar joint as well. With quite a long nail, that will be my preference of treatment. Yes.
Okay, sir. So agree. And the case was done by a colleague whom who wishes to remain anonymous. So after a lot of deliberations, So this was
done. What happens. This is what happens.
Yeah. So Dr. Alok, sir,
death by metal.
Okay?
Death by metal. Death by screws.
This is a poor fixation, of course, because there is no home screw, first thing. If at all you are planning to go for 3 screws, the construct is very precise. Posterior medial to anterolateral, posterior lateral to anteromedial, and then those 3 screws at least are to be there. Or if at all I'm in doubt, the approach probably is anteriorly, anterolateral or what, I guess.
It looks like a dual approach, sir, an anteromedial with
Okay. So I don't know what he did from the medial side, but this is not this is a very poor fixation. The screws are straightway perpendicularly holding. They are not having sufficient angles, and there are too many things. We cannot go into elaboration.
Sir, yes, Pradeep, sir.
So if you just go back the pre-op. So I know everybody was talking about hindfoot nail. I really love hindfoot nail. I think it's a very forgiving implant. But in this case, if everything else is good, he's a well-controlled diabetic, may not have a very mild neuropathy, no nephropathy. I think if it is a neuropathy and nephropathy, it's a very, very bad combination. I think there are multiple papers now out there which mentions we don't need to just look at neuropathy. And I think Balvinder sir has already mentioned on that as well. There would be a role of just doing a ankle fusion in this case. But not with screws. I have had one case where I did screw. I can tell you I got away with it, but in the later part, every time the patient would follow up, I would keep my fingers crossed and I would just pray that he heals, but he healed in valgus. So in this case, there is a role of plating as well. I don't think so there is role of any screws. So there is a role of plating where you could take out a lateral approach, you take out the fibula plate, use the fibula for your approach as well as bone graft, and then you could use a lateral plate. I think now we have special lateral plates for ankle, both Arthrex, or you could use a Philos plate reverse way and use that, but not this. Not this.
I completely agree
And
with you.
also,
Sir.
sorry, one more thing.
Sir.
Reduce the ankle. Reduce the
ankle, yes.
Ankle has not been reduced. You need to push the talus really back. I think that is another very, very important factor.
Right, sir. I agree with you. So, in fact, I did have a chat with the operating surgeon, and he did concede that intraoperatively they had a lot of difficulty reducing the ankle. I mean, this is the best position that he thought that he could get, and agreed that it was an inadequate reduction and perhaps an inadequate fixation as well. But the good thing here was that the patient is a controlled diabetic. He has no other issues whatsoever, and he never had any skin problems even during this course of treatment. So 2 months post-operative, this happens, and the screws have cut out, and we can see that this has failed. And of course, nothing more to say about this. So, sir, at this point of time, what would we do? So now we have a failed ankle fusion. We knew that this would happen.
I will go back further. Can you go back another last slide, please? So, yeah. So now you have got only 3 problems. One is the implant which you have to remove. There is the dislocated ankle which you have to reposit back, and then the attempted fusion which you want to get. Okay, implant removal, yes, you can do it by hook or so many things. Then the talus. Now the bone stock will be a problem. Okay, so as mentioned by Dr. Pradeep, that the height must be restored to the best of the possible, whatever it is. So I think a part of talus will have to go. Now again, the choice is to go for a TTC and nothing else, because you don't have enough bone stock to put your plate or put your screws through talus to tibia. So that remains the only choice, an intermedullary implant.
Okay, sir. So going on to what I did and what my thoughts were, and sir, then you are free to give your critical comments and criticize them. So the patient was 50 years old. Physiologically, because he was a cop, physiologically you could say almost 40, even with his diabetes very well controlled.
You can go for a ring fixator before you do anything else. So anytime. Okay.
Which is what I did also, sir. So his subtalar joint was fairly good. And in a young patient, preserving the subtalar joint is, to my mind, would have some merits, and other things were good. So this is what I completely agree with you. So I thought that a ring fixator would be a good plan. And why a good plan? Because you could preserve the subtalar joint. The frame itself is very stable. You can compress it.
Yes, before you go any further, just want to say, after 3 months to 6 months of immobilization and suffering and morbidity and this and that, do you really expect movement at subtalar joint? Honest opinion. After such a long journey.
Yeah.
But after such a long journey.
But sir, this is what it was. I mean, this is not something that I made up. That fortunately he was not in a cast or a boot, and he was just limping his way with 2 crutches. That is what it was.
And that's the one reason of failure.
Perhaps, sir. Yeah. That also, the inadequate immobilization is also something which I will highlight in the concluding remarks, sir. This is already...
You mean to say he had subtalar movements present at that time?
Yes, sir, he did.
Okay. I take your words.
Yes. So, and another reason for choosing the frame was that even if you cannot get, because this is 10 months down the line, in a diabetic, if you're struggling to get the reduction, you can do a gradual distraction, get the talus down, and then get it in a position where you want to fuse it. So all these things are really possible. So again, I did the same approach, the anterior approach, and intraoperatively, I could get the talus in a better position. Now, ordinarily, I would have wanted to translate it even more back. That was not possible, got a temporary stabilization. I used an arch wire to sort of distract the subtalar joint, and this helps you to preserve the subtalar joint. This is the post-operative X-ray. The olive was used to compress the fibula to the talus and then compression across the ankle joint to fuse it. So this fused in about 6 or 7 months time. And the latest X-ray that I had of him was about 2 years. This was again 3 months back. And that is his function at 2 years of follow-up. He's doing reasonably well, gone back to his job. Yeah.
Do you think there was a bit of more dorsiflexion at the ankle, fused ankle?
Perhaps, sir, because one would err at the site, you know, when you're trying to...
The calcaneal pitch.
Yeah, the calcaneal pitch in this X-ray, I would agree with you, sir. And that usually happens when we try to compress it. So
that will result in further stress on the midfoot.
I think, Shantanu, we've got just 10 minutes left.
Anyway, I think yes, because on case-based presentation we cannot go because it's really difficult to contain yourself in time.
Yes, sir. So to just sum up the case, sir, if I may.
Yeah, please.
So to sum up the case, sir, like it has already been said, we do need adequate and appropriate fixation. Both are important. Immobilization time and modalities, as already pointed out by many speakers, including Dr. Alok, is so important. In diabetics, the rule of thumb is double the period of immobilization. Again, fusion in diabetics is not the same, like Dr. Pradeep already told you, Dr. Alok already told you. And finally, the key theme is medical management, good glycemic control, and address the secondary osteoporosis and modify your fixation and fusion strategies accordingly. So thank you.
Thank you.
Thank you so much, Dr. Siddharth. That was a wonderful presentation of case, and you drove your points home very well. Thank you so much.
Thank you, sir.
So since thank you. So since we have another 20 minutes or so, we need to move in quickly. And our next presenter is Dr. Abhishek Kinney. So may I welcome Dr. Abhishek Kinney. Unmute yourself, Abhishek, unmute yourself.
Okay, hi. Thank you, Shantanu. Thank you, IFAS. Thank you, my alma mater, BOS. It's always pleasure talking for us. I'll not waste much time in doing all these greetings. This is a Charcot midfoot presentation which Dr. Agashe had made with us, but I think there are a lot of key home points from this which I think are apt even today. So we know that Charcot foot gets fractures, dislocation with minimal or no trauma, and patients have, like in patients who have sensory neuropathy. So they can be deformity, they can have abnormal weight bearing, insensate foot, ulcerations, and infections. So in severe joint disease of foot and ankle, there can be fracture, permanent deformity and limb loss, and significant disability. So Charcot is painless and surgical treatment is futile. This was the age-old perspective of a normal orthopedic surgeon, maybe many few decades back. But today it's changing, and it can develop in a diabetic mellitus, develop without warnings and deteriorate rapidly. Like previously, it was most commonly due to leprosy and other peripheral neuropathies. But since we are sitting on a pandemic of diabetic, it can happen in diabetic without any warnings. So midfoot is most common, and as other speakers have spoken, in hindfoot, ankle, and forefoot is also seen. Multiple regions may be involved concurrently. So Brodsky anatomical classification says type 1 again is 60%, and midfoot involving the naviculocuneiform and the metatarsocuneiform joints are most common type. So what is radiologically features are 6 Ds, that is the mnemonic. It has dense bones, degeneration, destruction of articular cartilage, deformity, debris as loose bodies as previous speakers shown, and dislocations. MRI features, we need to kind of differentiate between infection and no infection. With no infection, there can be diffuse bone marrow signal abnormalities, joint erosions, and with infection, you may have a sinus tract or thick rim enhancements. So what is our management goal? Is to give a patient a stable plantigrade foot, which is easily shoed, and minimizing the risk of callus, ulceration, infection, and amputation. So pharmacological treatment, it's known, like bisphosphonate and calcitonin are found to be useful, but I think at best they are supplementary. In stage 1, we need a non-weight bearing immobilization in a total contact cast. It's like the house is on fire and you need to put off the fire. You immobilize the foot, rest it, and let the fire burn. How long? Till the swelling subsides, redness, pain has decreased significantly. So you need proper cast care. You need proper care, like, the treatment of that 6 to 9 months always continues, whether you operate or you put them on a total contact cast. In stage 2, you need protected weight bearing mobilization in an ankle foot orthosis like an air cast boot. In stage 3, when the plantigrade foot is there, you need to customize inlay shoes so that you avoid all these callosities and ulcers. In a non-plantigrade foot with recurrent ulceration and or osteomyelitis, you need debridement, exosectomy, stage correction, fusion with internal fixation, and rarely, sometimes, amputation. So what are the management options in midfoot? Conservative, like offloading shoes, treating the bone disease with medical treatment, preventing further foot fractures and orthosis, and surgically only when the disease is quiet and when the conservative treatment fails, you can do resection of infected bone, removing bony prominences, deformity correction, fusions, and rarely amputations. Exosectomy is effective and safe for treating Charcot midfoot deformities and ulcerations. And concomitant recurrent plantar ulcerations and severe equinesis have been shown to kind of improve when you add a tendo-Achilles lengthening procedure along with an exosectomy. So it's important that you address the deformity and the cause of deformity in totality. Like if there is a gastrosoleus contracture, you need to address it appropriately. So it has seen that medial ulcers heal in almost 92% and lateral ulcers heal less frequently in 38% when you do these two procedures together. Arthrodesis is indicated when the joint is unstable, pain or painless, but with recurrent ulceration and not responding to conservative therapy. So it needs to be staged if there is infection, and you need to kind of reinforce, as we all have been saying, long non-weight bearing protocols, protected weight bearing, and compliance issues. So arthrodesis with internal fixation, plates, nails, screws, external fixation, or internal with external fixation like a combi fixation. So this is a midfoot Charcot which came to us with this condition. We ended up with excision of sclerotic bone, deformity correction with grafting and plating as seen over here, and it went on to fuse satisfactorily. They used a long distal radius plate to kind of use it as part of his long segment fixation. So arthrodesis gives good results in like almost 70% achieve good healing. However, most series are small and different anatomical sites make it difficult to compare apples with oranges. They also have complications in diabetic Charcots like infection, hardware malposition, recurrent ulceration, fractures, implant failures, and fusion sometimes is seen in as low as 36% in some series. So you need to be careful that you are fighting a big giant and you need to be careful about all of these things. So to overcome this, there is a new concept, or it's not new anymore, it's almost a decade old, a concept of superconstruct. So what does this superconstruct? So if this is the foot where you have the calcaneum, talus, navicular, cuneiform, and the metatarsals in this architecture with plantar structures, fusion is extended beyond the zone, including the joints that are not affected to improve fixation, excision of sclerotic bone for adequate reduction of deformity without undue tension of soft tissue envelope. Strongest device is used that can be tolerated by the soft tissue envelope, and devices are applied in a position that maximizes mechanical stability. So what is this? So coming back to that same animation, this is what it is. It kind of, once fractures and dislocation happens, the soft tissue contracts on the plantar side and these all bones go haywire. This is what happens, soft tissue contracture. So how do you kind of address it? You resect the bones over here so that all of these fall in one line like this. That reduces the tension of soft tissues. Fusion beyond the zone of injury, wherever these things are, you make sure that your implant is kind of placed at a point where things are like good healthy bone. And plantar plating, that's what they advocated, thinking that plantar plating has an advantage of bearing more stresses in the foot, which has like gravity acting perpendicular to the plate position. And especially when you do this, this is what they said, that tension is generated plantarly and compression generated dorsally. So if this beam is cut and this is how it's done, it kind of gives maximum stability, mechanical advantage. So techniques which are based on normal orthopedic principles are abandoned and maximize stability to bridge the area of Charcot dissolution. So this is what it comes as, sorry. And indications are poor bone quality and extended healing times are anticipated. So plantar plating, locking plates are used, and axial screw fixation. So this is a Charcot from their paper, from Samarco's paper, and that's what they've done. They've put plantar plates, they've extended beyond the area of Charcot, and axial screw fixations, whether anterograde or retrograde, by shortening and making things settle down in this manner. So cannulated screws can be used. Guide wires help temporary maintenance, less soft tissue stripping, and lesser chances of implants being exposed. Rarely, we need to do amputations in unstable arthrodesis, recurrent ulcerations, but in current series, there are as low as 3% in some series. To conclude, for midfoot, it's a major complication. Charcot midfoot is a major complication of diabetes. Can develop suddenly without warning and rapidly progress. Any sensory neuropathy can cause Charcot. Stage 1 is painful and can lead to severe deformities and ulceration. TCC and non-weight bearing are very important in early stage. Surgery when indicated. In recurrent ulceration, unbraceable foot, acute fractures, dislocation, or infection. Common procedures include exosectomy, with Achilles lengthening and arthrodesis, and treatment needs to be tailor-made. Stage, soft tissue, deformity, medical, and social status are main deciding factors. Thank you.
Yeah, thank you so much, Abhishek.
Thank you,
It
sir.
was a comprehensive presentation. Questions from the panel, if any? Well, I guess for the want of time, we'll move forward and go to the next speaker, that is Dr. Alo. Dr. Alo, can you start your presentation, please? Hello, can you hear me?
Can you hear me now?
Yes, yes.
Hello.
Can hear you now.
Can you see my screen?
Yes, yes,
Okay.
yes.
So first, I had one question to Abhishek because Dr. Shantanu mentioned him the smartest or the handsome, most handsome. So I am always envious of him. Anyway, regarding the plantar plates, so plates, I mean, so Abhishek, we just can apply only one plantar plate or more than that?
I think only one plantar plate.
Only one, yeah, that's all. For the first metatarsal or medial column, only the medial column we can apply only one.
Yeah. Medial column is the most important.
Okay, because the plates were confusing. That was the confusing one. Anyway, I'll start with my presentation as we have to cut short. So 4-foot problems, though there can be enumerable, but still the longest of the journey begins with the first step. Why it's not moving now? My goodness, this is just yeah. So there are different causative factors. These are the causative factors, technically speaking, neuropathy, vasculopathy, or decreased immunity. But the most important part, which has been noticed by me, is the ignorance. And ignorance on behalf of the patient, on behalf of the society, and as well as ignorance on behalf, I can dare say, on treating doctors. So these are the different causative factors, like increased plantar pressure, thickness of the plantar tissue or fat pad atrophy, decreased thickness, and deformities, claw toes resulting into this, dorsal ulcer, while the hammer toes resulting into the plantar ulcers of the tip of the toes. Callus, whether it's a cause or effect, it has yet to be decided. I feel it's more of the effect rather than the cause. I would say cause of the ulcer rather than effect of the pressure. While the limited joint mobility, because in the toe-off time, this limited joint mobility and the tight TA, there results in the much of the increased pressure. The body weight, abnormal posture, and the different footwear, this kind of thing, can result in 4-foot problem. Slow score test is a most important test for whenever you are looking at any problem in the diabetic foot, but yes, more so in the 4-foot problems. As far as the management of foot care, it has already been told by all the speakers. So I'll just present a few cases like this guy who had come with already a problem in the 5th toe deformity and a big plantar ulcer where the distal metatarsal osteotomy was done. And and apart from it, he had a TA tightness. So his percutaneous TA landing was done over here. And this is 2 months follow-up. Then this is what, 7 months. And then this is almost 2-year follow-up. He never ever had the problem at this, except he has to manage his foot. The foot care continues even after any surgery. Now, this is another case where the third metatarsal osteotomy was done, and this is almost 3 years follow-up, then up to 7 years. In the meantime, he lost his second toe at some other place. Look at the fat pad atrophy. Almost the bones are directly coming onto the floor. There is hardly any soft tissue in between. So these patients, they require a lot of care. This one, bilateral forefoot ulcers after debridement of the callus and debridement of the ulcer on the left side. The metatarsal osteotomy was done, which heals eventually without any complication. Of course, the gastroprecision is the key in all these patients. A chronic ulcer for last 10 years at the head of the first metatarsal here, a callus or excisional orthoplasty was done. That ulcer heals up, and he has maintained it for almost 2 to 3 years, and then he was lost in follow-up. This is quite a recent case, almost 6 months ago I did. This patient had a lot of problem, a non-healing ulcer over the head of the first metatarsal or other in the forefoot, a deformed toes. This was his X-ray. So I decided to go a step further and then did a orthodesis of the first TMT through the bad skin which he had. Also, this excision of the neck of the fourth and fifth metatarsal was done. His third toe was amputated. And this is how the foot looked after the whole of the reconstruction on table. Then it healed up slowly over a period of time. And now it's almost 4 to 6 months, I guess. And this patient is walking. I have a video if needed. I can show it. So he's now, he can wear his footwears and he's comfortable in walking. Now, there are numerous other problems like infection. Like in this case, there's an infection of the sesamoid. You can look over here, which was excised, and fortunately, there was no deep infection. So it was primarily closed. It went to eventual healing. Now, this case, this was being treated as an infective cases, though this was a very recent development. This ulcer, or rather an abrasion because of the footwear or sandal he was wearing. Otherwise, he was being treated on the line of the infection while he had a clear-cut Charcot arthropathy. The first, then look at this X-ray of the October, and this is in January. See, now further destruction is progressing, but this is healing well. This is stabilized with the conservative treatment of it. So forefoot neuroarthropathy is also quite common. This was another case. Here, incision and drainage was done to take out the infection, thinking that it was infected, but this was really Charcot. The wound healed up. There was no pus discharge, nothing was there, but this was a Charcot. Thank you very much.
Thank you, Alok Bhai. That was very quick and comprehensive. Nice.
Yeah.
Questions from the faculty?
Yeah, look, that was an excellent series of.
Hey, Monty, nice to see you after such a long time, man. And thanks to MOS, BOS, and IFAS all for giving me an opportunity. You're doing fine, man.
Thanks a lot.
Thank you. I thought it was a message that at 2:15 or 1:15 we have to hand over this screen. You can go on the forefoot problem, but anyway. So I'm open to questions if there are any.
Manoj,
Alok bhai, very good cases. Just few things for your, especially your plantar flex metatarsal. I know we talk about callus, but actually it is not callus. That's why I would also do the same thing on metatarsal head excision. We have had few cases where we have done, but just on a technical term, it is not called callus.
No, certainly not. Callus. No, I didn't say callus. I say callus about cause or effect. See, callus to me, like it's a callus over at the head of my fifth metacarpal. So callus is a result of the increased pressure. And then that callus becomes like a stone strapped around on his sole, which cannot be moved, and the patient gets double pressure from the surface, from the floor, and from the bone. And that callus breaks up into a blister or
not callus. Sorry, okay. I think we got it wrong. Not callus, it's callus arthroplasty. Sorry, that's what I was talking.
No, that is callus. That was callus.
Okay. One more thing. Have you tried doing a BRT osteotomy to offload the metatarsals?
Which osteotomy?
BRT osteotomy. It's a long oblique osteotomy to elevate
No. That's where here at this point I like to say in diabetic foot is unforgiving and diabetic foot is most forgiving. Either way. Like in these cases, these are just short procedures. Even percutaneously, I'm doing it. Sometimes I'm not excising the head. Sometimes I'm just doing a percutaneous osteotomy and leaving it as such. Let the patient walk onto it, because then it readjusted itself and the pressure point is gone. The sole idea is to No internal fixation, nothing is needed. Patient can walk.
So that's what I'm saying. For prominent metatarsal heads of second, third, and fourth, I've done in 2 cases. That's why I'm asking, where I have done a long oblique osteotomy or a wedge taken from the base of the second, third, and fourth, and let them walk.
Okay.
So instead of excising the metatarsal heads, they elevate it.
The problem, what I personally feel, once you remove the head, that area becomes more normal. You know exactly where the callus was. So it's the directly I'm removing 10 minutes, 5-10 minutes job. I'm directly removing the head, and the whole area becomes as good as normal. Of course, there are chances of recurrent ulceration. So it's a 10 minutes job hardly.
There are too many ways to skin the cat, so it's okay. The whole principle is followed is to decompress that area from the bone. So I think that's what the message has to go through. And I think that role of TA tendon lengthening is extremely important, because any forefoot pathology is related to a TA tightness. If you don't release that TA, that forefoot pathology is going to go on and on and on, because that's the compensation that the body has done. And that's why the forefoot pathology has to be addressed by releasing the TA tendon. I think that's the second point that needs to be remembered. So Shantanu, can I wind up by just?
Yes. I was coming to that, sir. Respecting the time, we should wind up. But before that, maybe a word or two about the vote of thanks from our president to MOA and BOS.
So thank you, everybody. I think first I should thank all the faculties for having spent their Sunday with us for 3 hours. And thank you, everyone, starting from Dr. R.K. Modi, Dr. Dhanesh Kamerkar, Dr. Sharma, Dr. Alok, Dr. Pradeep Munot, and Dr. Balvinder Rana, and Abhishek Kini. And Abhishek Kini.
You also mask yourself so that we can take a screenshot and save it for posterity. Abhishek
is hiding back.
Abhishek has left.
Yeah, he is. I'm going ahead. Right. So yeah,
like to thank BOS, the Momentum team, and the organizers, and of course, thanks to my own secretary who has done all this hard work in a very short time. And thank you very much, because this topic was very close to my heart, because that's my theme this year. And I think we should continue doing more on diabetic foot and spread it out to the other regions and take this forward. Thank you, everyone.
Thank you.
And have a great Sunday for the rest of the day. Thank you.
Thank you.
Thank you very much. Thank you.
Bye.
Bye-bye. Bye-bye.
Dr. Kumar Shantanu.
See you in Goa, Mahendra.
Bye. All the faculty, especially Dr.
All are welcome. All are welcome to Goa. Don't worry about the Goa.
All of you.
Hey, my beer is already chilled, so let me go.
Personally, I didn't know that there are so many things in diabetic foot. That's why I was sitting right from the beginning till end, just to learn, educate myself. And,
the ones you open a diabetic.
Yeah, Alok and me, we are together, with Dr. Dholakia way back, maybe 27 years back, 26, 27 years back. Pradeep is trained from Bombay Hospital also. Pradeep, that is the history of how Alok and me were together. And it was really enlightening.
94, 95. Yeah, 94, 95.
94, 95. It's so enlightening. And on behalf of the IOCAN organizing committee, the Maharashtra Orthopedic Association, as well Bombay Orthopedic Society, I extend my heartfelt thanks to all the faculty. And from Dr. Dhanesh Kamerkar also, we learned that how to preserve the vascularity is also extremely important. So much thanks to you. So we are thinking of keeping a diabetic foot symposium in Vairak also, which is scheduled in the March. I hope we'll invite you there to learn more about it. Thank you very much, and have a wonderful weekend today. Thank you.
Thank you.
Thank you.
Thank you.